All right, good morning, everyone. Thank you for your patience. Welcome to the Greater Houston Industrial Hygiene Council. And today we're discussing COVID-19 and related occupational safety and health topics. Welcome to, virtually, welcome to Houston, the Texas Medical Center, the University of Texas Health Science Center School of Public Health. So we are at the Southwest Center for Occupational and Environmental Health, which is a NIOSH education and research center. And we have 4 academic training programs: industrial hygiene, our occupational environmental medicine residency, occupational epidemiology, and total worker health programs. And then we also have some non-academic programs in our center: outreach and continuing education with our core subject areas, and we specialize in offering these specialized trainings, training design and facilitation. And then we have our research and practice, which our investigators promote health, safety, and well-being for workers in their communities and improve business performance in federal public health region 6, which is Texas and the surrounding states. We also have a pilot projects research training program for new investigators and transitional investigators in occupational health and safety. And upcoming, just to give this a little tag, is our hopefully 2021 conference that will be here in Houston in December 2021. And that's a collaborative agreement with NIOSH on shaping the future to ensure worker health and well-being. And we're focusing on research training and policy. So that's a little bit about us, and we facilitate GHIHC. We've done that for many years, and so we're happy to have you all here with us virtually today. So just a little bit about Webex. Today, you're not going to be able to, as attendees, use your camera or microphones, so make sure you use the chat box or the Q&A box for all your communications. And if we ask you any questions, please put your answers into the question and answer box, and make sure you select that all participants so we can all, as panelists, hosts, and attendees, communicate with you. If you're having any issues, make sure you close any other applications. You can change your audio if needed. And to do that, you can just click on switch audio to do that and call in, or choose another audio setting. So this event is being recorded today. And this is our lineup of speakers. We're going to go ahead and start with Dr. Berkheiser.
Oh, Michelle?
Yes.
Dr. Hotez has just joined us.
Ah, okay. All right. Well, Dr. Berkheiser, you are off the hook, and we're going to go ahead and start with Dr. Peter Hotez. So I'm going to turn it over to Dr. George Delclose, who is a professor, deputy director, and a medical director of employee health here at UT Health, and he is going to moderate our first session.
Thank you, Michelle. Well, first, before we started, Dr. Hotez, welcome. And are you able to turn on your video by any chance? And just want to make sure that you're able to talk, that we can hear you and all that.
Yes, here I am.
Hi.
Hi, sorry I had trouble getting on. It would only let me on as a attendee, not a panelist, so I was...
Well, thank you. It's a pleasure to have you on. So let me just give you a short introduction. Actually, Dr. Peter Hotez really doesn't need an introduction. It's pretty much the entire nation already knows him as a tireless advocate for science-based decision-making in our current fight against COVID-19, since he's appeared virtually on every major TV channel since the beginning of this saga, as well as in newspaper interviews for the New York Times, Washington Post, and Wall Street Journal, just to name a few. Professor Hotez is Dean of the National School of Tropical Medicine and Professor of Pediatrics and Molecular Virology and Microbiology at Baylor College of Medicine. And he's also the Director of the Texas Children's Center for Vaccine Development. And a fellow at the James Baker Institute for Public Policy at Rice University. He's a member of the National Academy of Medicine and the American Academy of Arts and Sciences. In 2011, Professor Hotez was awarded the Abraham Horwitz Award for Excellence in Leadership in Inter-American Health by the Pan American Health Organization at WHO. As head of the Texas Children's Center for Vaccine Development, he leads a team that's developing new vaccines for a whole host of tropical diseases and infections, and that includes now a vaccine that he's working on for the SARS-2 coronavirus. These are diseases that, as we know, affect hundreds of millions of children and adults worldwide, and he's been championing access to vaccines globally as well as in the U.S. So it's my pleasure now to invite Professor Hotez to speak to us on Preventing the Next Pandemic, Vaccine Diploma in a Time of Anti-Science. Welcome, Dr. Hotez.
Well, thank you. I don't know exactly how you'd like to proceed. We can either do this as a moderated discussion or a formal presentation. I'm in your hands.
Well, if you want to start off, I mean, we can go until a few minutes before 10 and allow some time for questions, because in this format, typically questions are, you know, there are lots of them, and I think it interests them.
Yeah, I think that's fine. I don't ordinarily hear too many pleas for more PowerPoint slides. I just haven't been hearing them a lot lately. So
we can do this any way you want.
So why don't I just, you know, rather than just talk about the book, why don't I just give some thoughts on where I think we're headed with COVID-19 and some of the real urgencies right now, and then where I see we're going with vaccines. How does that sound?
That sounds great. And then
Okay.
I know I have some questions as well as the rest of you.
Sure. So let me just speak for a few minutes, and let's put the emphasis on answering questions. I think that might be more interesting. So, you know, right now we're going through an awful period where we've all been predicting the steep acceleration of COVID-19 this fall. I think it's even exceeded many of our expectations in the wrong way in terms of a number of new cases. We're probably going to hit 200,000 new cases in a couple of weeks, maybe by next week, 200,000 new confirmed cases a day, which we know is an underestimate by 3 or 4, so it could be up to 1 million new cases a day. And I'd never thought we could get there as a country. I thought we could be more disciplined and organized than that, but in part because we've never had a national response to COVID-19. It's always been fragmented and led by the states, with the federal government providing some backup support. That's where we're at. And the rise seems to be the steepest in our heartland, in the middle part of the country. North Dakota, South Dakota, Iowa right now probably have the highest single COVID-19 rates in the world. So the epicenter of the epidemic is in the north central part of the prairie states and the Midwest. So North Dakota, South Dakota, Iowa, Minnesota, and then now moving over into Wyoming, Idaho on the left-hand side, and into Indiana, Ohio on the right-hand side. And that's where the deaths are really going to start mounting up. I'm afraid we're going to be at 2,000 deaths per day. And so in a few weeks, COVID-19 will be the single leading cause of deaths on a daily basis in the United States. We are also looking at something equally catastrophic in West Texas. So El Paso right now, probably for, I think, different reasons from the middle of the country, also has equally high rates. If you had to pick the most, a single large metro area that's the single largest train wreck right now, it's El Paso. What we're seeing is massive surges on our intensive care units in El Paso and up in North Dakota, South Dakota. And the reason we get concerned about that is because historically we learned from New York in March and April, and Southern Europe, Spain, Italy back in the spring, that's when the death rate goes sky high, as we don't have enough trained nurses, techs, hospital staff, and remember how exhausting it is to don and doffing PPE all the time and constant, long shifts with no breaks. Things just go badly very quickly, and so we are seeing. I'm calling this a humanitarian tragedy unfold in West Texas, not only in El Paso, but in other parts of West Texas and in the north central part. So the great frustration that I've been having in making pleas on going on the cable news networks is none of these people have to die. We, especially given the fact that we've got good vaccines coming starting in the late winter, early spring, so that if we could just hold on as a nation and keep everybody alive for the next few months, we'll get them through to the other side and get them vaccinated, and they can live a normal life. But it's just been really frustrating for me to get elected leaders to understand that simple point. Everybody is so fixed on ideologies, and I just don't understand it. So we are looking now at 17,000 Texans who will lose their lives between now and February. None of those 17,000 Texans have to die. We're looking at 150,000 Americans who will die between now and February. None of those 150,000 Americans have to die if we could just implement aggressive social distancing in the places where we're starting to see surges on their ICUs. That's it. Of course, in face masks, but that's really it. That's all we have to do. It's not in perpetuity. And that's an important point, because the other piece of this is, in the past, if people who've been listening to me all year, I never had a bracket on the right-hand side. Anytime I was asking the country or Texas to do the social distancing and the masks, I could never give them a date when I could say, okay, then we don't have to do that anymore, just hang on a few more months. Now we have a right-hand bracket. We can bracket this whole thing off, knowing that good vaccines are coming. So we've got great news from the Pfizer and Moderna mRNA vaccines. Mind you, it's all through company press releases, which that's the only asterisk. People assume that the companies are being accurate in what they're saying. I think they probably are, but the pharma companies have not been good communicators this year, and so there's been a lot of hype, and so you have to be a little careful. But I think this time around it looks pretty legitimate. Pfizer will apply for the Emergency Use Authorization now. It'll take a couple of weeks to review by FDA VRBAC and CDC ACIP committees to make certain it looks good. We also have to check all the quality control, quality assurance of the manufacturing process to make certain that's not corrupted. It's still not full licensure, but Stephen Hahn and the FDA, speaking to them all year, and I think they've really rebounded from some initial missteps, and we'll be certain that good vaccines that are safe are released to the public. We have 2 other vaccines that are going to come along after that, so I think we'll have 4 vaccines in the coming weeks. The Moderna Pfizer mRNA vaccines, the 2 adenovirus-based vaccines from AstraZeneca Oxford, and also J&J. So I think we'll start getting vaccines going, and we have a vaccine that we announced earlier this week. We made a recombinant protein vaccine, sort of an older school technology vaccine that uses a technology. It's around 40 years old, the same one used to make the recombinant hepatitis B vaccine, used all over the world. And the significance of that is it just requires simple refrigeration, low cost. It's made in India. The hepatitis B vaccine is made for 45 rupees a dose. And you're probably asking what 45 rupees is. It's about 60 cents a dose in India. So we think we can have our recombinant protein vaccine made at that price and simple refrigeration. So this could be the first low-cost COVID-19 vaccine for the world. It's being scaled by our partners, those BioE Biological E in Hyderabad. they're making 1.2 billion doses, and that's exciting for us since we've never made 1 billion of anything before. And it's now being tested in 5 sites in India. So we made that announcement. So that may come in, and that may come in the US as well. So there's a whole ecosystem unfolding around vaccines. And provided we can keep everybody there to be vaccinated by late winter and early spring. So that's kind of the big picture. I'm just so upset about the unnecessary loss of life that I'm seeing. And one of the things that I'm doing, you know, and of course things are so polarized in the country, right? I mean, the White House is more or less checked out. They're not really leading any national efforts for control. The Biden administration, you know, has limited abilities to reach across the aisle, and we'll have to see how much interest they have. So we have this gigantic gaping hole. And so what I'm doing now is, just because I'm trained as a physician scientist, and I went into this so I could use science to save lives, and that's what I'm trying to do. I'm reaching out to conservative sites now to try to get that message of hang on, save lives. So I was on Fox News welcomed me back after being blackballed for a few months, so that was good. The Daily Caller, the DC Examiner, reaching out to others just to fill that gap that's there right now, because there's not a lot of voices going to out of the conservative sites and media channels to send that message that COVID is not a hoax. There's no such thing as health freedom. That's a fake concept, and we need to save lives right now, and we can save all of them over the next couple of months.
Well, thanks. So let's do a chat here. There are 3 topics I'd like to talk on while people feel free, by the way, folks, to start entering your questions in the Q&A, and I'll take them. One is to echo some things that you have said. The first is, you're right, there is exciting news about vaccines. However, most of it is coming from the press. Although I did hear that this morning, I haven't checked it out, that AstraZeneca has published its results in the Lancet this morning.
Yeah, that's a phase 2 result on immunogenicity, not on protection.
Okay. Because the phase 3 trial is going on in both in the UK.
Right. I think, you know, it went on a pause for a while, so that delayed things because there was concern about a potential safety event that I think they resolved. It wasn't related to the vaccine, but that slowed things down a bit. They seem to be back on track, so I'm hoping that will be one of them as well. I mean, the other thing about these next vaccines, I mean, Pfizer and Moderna really raised the bar in terms of efficacy, 95% efficacy. The others may not do that well, and then you might say, well, is there any role for those vaccines? And I would say yes, because these are all brand new technologies, and as well as ours, we don't know the durability of protection, how long protection will last. So it's possible that the Pfizer and Moderna vaccines will protect for 3 months, and that's it. So I don't think that's going to be the case, but it's a possibility. So that's why we have to get. So even if the AstraZeneca Oxford vaccine, say, protects 65%, it may still have value because it may have a longer durability of protection, and that's why we need all of those vaccines. And then the question I'm often always asked is, hey, Dr. Hotez, which vaccine are you waiting for? And the answer is, I'm not. I'm so upset about what's happened in the country and the widespread transmission that I will take, and you won't have a lot of choice. You'll take whatever vaccine. You have to really accept whatever vaccine is offered to you. And I say that's okay because they all work by the same way. They all work by inducing high levels of virus neutralizing antibody. And that's what will keep you out of the ICU and in the hospital. And if later it turns out the vaccine you got was not the best one of the lot, so what? You can get vaccinated later on. Don't overthink this. And, too many people are saying, I think I'm going to wait for that vaccine or this vaccine. I would not recommend that. I'm going to take whatever one is offered because it's better than nothing. And later on, if I need to get boosted with one of the others, that's fine too.
So that's some good advice. I'd like to get back to the issue of messaging. Back in, I believe it was in May, the Royal Society in the UK published analysis of what had gone wrong in the UK and why. And at the top of the list something that I think is very applicable to our country as well, which is mixed messaging. Lack of consistent messaging from the authorities at all levels. And they did issue recommendations that were at odds with each other. And I think a lot has happened here in the same regard. Would you agree?
Well, it's even more than that. I mean, and I study this a lot because in addition to being a vaccine scientist and pediatrician, I've been going up for the last decade or so going up against the anti-science movements. I'm now the #1 target for the anti-vaccine lobby because I have a daughter with autism, and I wrote a book a few years ago called Vaccines Did Not Cause Rachel's Autism. So Robert F. Kennedy, who's probably the lead anti-vaccine activist in the country, on his Instagram site calls me the OG villain. And I had to look up what OG is. It means original gangster. So we're hearing from the original gangster villain today. And I know how these guys work. And people are very dismissive of them. They try to say they're a fringe group. They are not. They have money, they have power, they have clout, and they dominate the internet. There are now 480 fake anti-vaccine websites, all revved up on social media. They've turned Amazon basically into the largest promoter of fake anti-science, anti-COVID prevention, anti-vaccine books. This is causing a lot of damage. So the way it's often portrayed is sort of a passive thing that we sort of screwed up on our messaging. It's much more nefarious than that. There is a very aggressive anti-science disinformation campaign. And I'm sorry to say it really started in Texas. It began around 2015, 2016, around the time of the presidential election. Organizations like Texans for Vaccine Choice were formed under this fake banner of health freedom, medical freedom, and it got a lot of money from typical donors of the Tea Party. And then we stopped vaccinating kids in the state of Texas, especially in the Austin area, up in the North Texas area, parts of West Texas. Then it spread into Oklahoma and then became a national movement. And then in 2020, those same groups that were campaigning against vaccines under this banner of health freedom then began glomming on protests against masks and social distancing and contact tracing. So it became a full-on anti-science movement. And then the other thing that happened this summer was those same groups exported it to Western Europe. So RFK Jr. was the featured speaker at a rally in Berlin, an anti-mask, anti-vaccine rally in Berlin. It brought, I forget the number, 50,000 people. They tried to storm the Reichstag, the German parliament. And CBS News reported that it was sponsored by QAnon and neo-Nazi groups. So this thing has taken a very dark turn. They've been protesting Trafalgar Square in London and Paris. So this is a full-on global anti-science movement. And then, to make matters worse, you have the Russians piling on. So there's even a new term for it called weaponized health communication. They are doing everything they can to destabilize the country and flooding our internet with anti-science, anti-vaccine messages, and they go up against me a lot. And that's really tough, fighting Vladimir Putin. And then, unfortunately, the president took a very dark turn also, starting in May, when he decided to stop trying to fight COVID-19. And he basically turned around and started calling it a hoax, trying to claim the deaths from COVID were due to other causes rather than COVID, that these fake concepts of herd immunity, as well as discrediting masks. And finally, he brought on Scott Atlas to lead the White House Coronavirus Task Force, and he's caused an enormous amount of damage. So you've got, and of course, the Murdoch media empire is not helping things either. So even the Wall Street Journal now has been putting out op-eds discrediting masks and that sort of thing. So, I have to be careful how I say all this because it makes me sound like a crazy person, just saying that, when you start talking about the Russians and the Murdoch media empire and QAnon and neo-Nazi groups, that, I sound like one of those people who throws things at the TV. So I have to be careful how I say it, but it's actually, it's all really true. And we have to figure out a way how to dismantle that anti-science empire that it's become.
Well, Thanks for that. I happen to agree with you 100%. The questions are starting to roll in. I'm going to give you one of my last one, and then I'll turn it. I'll start reading from the audience. And this is a little bit of a change in gear because it's something that's been on my mind. So, I do evaluations of exposures, COVID exposures, and make decisions, et cetera. And one of the things that is happening now is, of course, we're 9 months into this. On one hand, it's a short period of time, and on the other hand, it's enough time to go by, that has gone by, that the issue of possibility of reinfection comes up, especially at a time when we're going to be seeing other respiratory infections that usually happen in the winter. And so the typical scenarios that I get faced with are somebody had their first infection back in March. They got over it, maybe even at a time when we were still doing double negative testing to return to work, and they were negative, and now several months later, they have an exposure, and they may be symptomatic or asymptomatic, and the issue is, what do you do? We know that there have been a handful of cases reported of reinfection, but using technologies that aren't readily available in the clinical setting, like comparing viral genome sequences and things like that. So what would you suggest for the practitioner? We know that people have persistent positives, but we don't know. Most of them resolve soon, but not everybody. So what do you do? Because every time you make a decision to quarantine somebody, especially if they're a healthcare worker, that's a lot of days lost from work. And the number is going to increase because we have more and more people with a past history of a positive infection coming into the respiratory system.
Yeah. I mean, there's about 10 questions in there, but let me see if we can unpack it a bit. So I think, first of all, in terms of reinfection, I think the scientific community is not in total agreement on this. I mean, you're right. The number of confirmed cases of reinfection is small. I think it's around 30 cases globally. And, and given that we've had about 50 million cases, potentially that's 1 in a million. But there are individuals, there's a professor at Imperial College London who feels the number of actual reinfection cases is much, much higher. I think a lot of it depends on levels of virus neutralizing antibody achieved after initial infection and other factors. So, when we look at our vaccine, say in non-human primates, when we want to compare them to various convalescent serum, we worked with a group at Duke and Emory, and they find 3 groups: those with asymptomatic infections, overall of pretty low levels of virus neutralizing antibody; those who were hospitalized higher; those who required intensive care, really high serious infections. And you want to get your antibody levels up to the serious. So what about those asymptomatic ones? Or low-grade fever or low-grade symptoms that had low virus neutralizing antibodies, because we know those decline. So perhaps by the time, if they were infected in March with one of those, they might not have any virus neutralizing antibodies. But then you've got individuals like my colleague Akiko Iwasaki, who's an immunologist at Yale, excellent immunologist, who finds lots of memory B cells, long-lasting T cells. So even though you're not measuring antibody, there's still immunological memory there. So those individuals should still have either total protection or greatly reduced severity of illness. So I don't think one of the things that the other way to look at this is the following. We know that individuals back in the early 2000s who got the original SARS, the severe acute respiratory syndrome, they had pretty high levels of antibody. They were sick. If they recovered, they were generally seemed to have high levels of antibody persisting for years. On the other hand, you have some upper respiratory coronaviruses that not many people hear about. There's at least 4 of them. I think 2 of them are beta coronaviruses that just cause respiratory symptoms, and those individuals do get reinfected. So I think that the story that's going to come out is COVID-19 is going to be somewhere in the middle. It'll act a little bit like SARS-1, where you don't get reinfected, and a little bit like the upper respiratory viruses where you can. But I think relatively it's going to be uncommon. And the hope is that when you get vaccinated, you get high levels of virus neutralizing antibody. It won't be an issue, number one. And number two, even if you're previously infected, and don't know it and get a vaccine, you're going to get a big boost because you've been primed with that initial infection.
Great. Well, let's continue with the vaccine questions now that we have the audience. So, let's see, Dr. Hotez, do you have concerns about the process of 2 doses separated by a set number of days between doses and patients being compliant with that process? Do you recommend, even if you receive the vaccine, those patients still need to social distance and wear masks? 2 questions.
Yeah, I mean, if you look at the phase 1 data, the numbers of the amount of virus neutralizing antibody in the recipients who got a single dose of any of the vaccines, except I haven't seen the J&J one, except for the J&J one, was not very high. So you're definitely at risk of breakthrough infection if you just get a single dose of the vaccine. So yeah, I think, you should, if you've got a single dose of the vaccine, you should still behave as though you haven't been vaccinated. And then once you get that second dose, about 3 weeks, it's 3 weeks later in the case of the Pfizer vaccine, a month later in the case of the Moderna vaccine. I maybe have it the other way around. No, I think that's it. Then you develop an immune response a week later. So roughly it's about a month to 5 weeks, 4 to 5 weeks from the time you get your first injection until the time you get your second injection and antibodies. The J&J vaccine, they're trying to look at this as a single dose vaccine, so that would be obviously an advantage, but that's the way how it would proceed. Right.
It seems that what little we know through the press, I guess the adverse local reactions tend to be more common after receiving the second dose than the first dose. And that's
what we saw at the phase 1, phase 2 data, and that's what we're hearing. There's been a lot of interviews ranging everything from Dr. Oz to various cable news networks that they've interviewed people, and the second dose more likely associated with fever, headache, malaise, but not too bad. I mean, as we start vaccinating millions of people, there will be some, that will have severe reactions, and hopefully it won't be too many. But fortunately, we have a pretty good system of data safety monitoring in place.
Well, speaking of safety, would vaccine be given for pregnant women?
That's being evaluated. So, and that often takes the longest. So once you identified your adult cohort. And the good news is, at least from the press releases, both from Pfizer and Moderna, seems to work well in older individuals. So that's really good, because flu vaccines, are not so much that way. But it looks like that looks pretty good. And then what's often done are two types of additional studies, step-down studies to look at kids. And I think those studies are starting. But we'll lag behind. And pregnant women often tend to be the last because of all of the potential safety concerns. But I think we will see data from pregnant women and kids, hopefully relatively soon. But I think for now, we'll have to see what the recommendations come out from the guidance that comes out of ACIP and CDC for use of the vaccine. I think probably, at least initially, will not be to vaccinate pregnant women, but we'll see. I mean, because we know pregnant women are not doing well with this vaccine, with this illness. We were seeing lots of ICU admissions and that sort of thing for pregnant women. So they may just go ahead with that for now.
And in addition, it looks like the priority categories for who gets the vaccine first, frontline healthcare workers are there at the top of the list, and a huge proportion of them are women of reproductive age. And so that's going to be an issue with pregnancy at the time of deciding, what can we do?
I think so. And then first line responders, I'm having a little bit of not a battle, but we're all talking about 65 as the age cutoff for the next cohort. But, one of the things that I've noticed, especially in the Hispanic and African American communities, is 30 to 35% of the deaths are under the age of 65 from COVID in those groups. And so it's, fathers, mothers in their 40s and 50s that are really getting hit hard. So I think, keeping it at 65 is too restrictive. I think we should lower it down to at least 60, maybe 55. if we can. I think it's going to be really important to protect those populations.
Thanks. Here's a good one. Some countries approved a Chinese coronavirus vaccine, Sinopharm, for emergency use for its frontline healthcare workers. So what's the significant difference in ethical consideration and trials between the Chinese Sinopharm vaccine and let's say the Pfizer Moderna vaccines?
And there's also the Russian vaccine. So the Russian vaccine is an adenovirus-based vaccine that has some similarities to the AstraZeneca and the J&J vaccines. And the Chinese Sinovac vaccine is a totally different, it's an old school vaccine like ours, but it's different. It's an inactivated virus on alum. And there the problem is that they're already releasing it for use in populations without revealing results of phase 3 trials or limited phase 3 trial data. And I have a problem with that for a number of reasons. Well, one, the Russians, keep on portraying this as a heroic scientific achievement. They're even calling it Sputnik V or Sputnik 5. And I say, look, it's actually not that heroic a scientific achievement. That's an old school problem in virology to make vaccines that induce neutralizing antibodies to the spike protein. So the hard part of vaccines is not so much in the design of vaccines typically, it's all in the quality control, quality assurance to make certain that you're not skipping steps, either for safety testing or for manufacturing. And that's what worries me about the Russian and Chinese vaccines, that the level of quality control and quality assurance is not there. I don't have a sense of what they're doing to do what organizations usually do to export vaccines, which is secure pre-qualification by the World Health Organization. I don't have a sense that that's going on. And then you have this other situation where they're exploiting the fact that the U.S. has pulled out of the WHO and the COVAX sharing facility, so that now countries are desperate for a vaccine, and they're making one-off deals with the Russians, the Chinese, and it sort of smells very Cold War-like in the way that's happening. In fact, there's even a new term that's been used to report on this called vaccinationalism, which is something we've never done before. We've never talked about the Russian vaccine or the Chinese vaccine. I mean, even the oral polio vaccine that was developed in Dr. Albert Sabin's laboratory was actually first scaled in the USSR right after the Sputnik launch at the height of the Cold War. The two countries put aside their ideologies to work together. And now we've gone into a terrible place where we're going in the opposite direction.
Can you speak to how the rate of COVID-19 mutation might affect the efficacy and adjustment of vaccines to keep up?
Yeah, I mean, RNA viruses do mutate at pretty high rates. So far, I've not seen any evidence that the mutations are going to affect the ability of the vaccines to protect. So, I often get asked, is it going to be like flu where we have to get a new vaccine every year? I don't think that's going to be the case. I hope not. That'll create a lot of problems. But, that may happen down the line. But for now, it looks like the vaccines are good to protect against. They're not even strained. We call them lineages. I mean, for instance, that's how we were able to determine that the virus that caused that terrible epidemic in New York in March and April came in from Europe, for instance. But I don't think it's going to be enough to have an impact on vaccinations.
Well, given the uncertainties of how long immunity lasts, at this point in time, should someone who's been infected in the past still receive the vaccine when available?
Yeah, I think they will. I think they probably will. So, because we're not going to bother testing everyone to see whether they've had the infection before. Right. Go ahead and vaccinate, and if they've had previous infection, if anything, they'll get a boost because of it.
Right. I thought CDC had actually come out and said more or less what you just said in that way, but I was checking the website yesterday, and they have a phrase there saying that because the information is still accumulating, they're not pronouncing themselves on this, although I thought they had.
It may be under discussion by ACIP, but intuitively, given the complexity, things are going to be complex enough vaccinated people. If we have to start doing serologic tests beforehand to see whether they've been infected, it'll just be a mess. I think operationalizing it's going to be too problematic.
Right, and especially if the vaccine is safe, there may not be any harm in getting it anyway, right?
That's right. I mean, I would say that if you've had the infection and know you've got lots of virus neutralizing antibodies, you may not rush to the front to get the vaccine, let others do it. But other than that, I think we're going to have to just, there's so much infection raging right now that pretty soon a significant percentage of the population is going to be infected with COVID anyway by the time the vaccines are out.
Yeah. Okay, here's one. Well, let's see, Garland is asking a little bit of a switch. Can you address dose response in relation to severity of COVID illness?
Yeah, I think it's a pretty soft call. I think what he's referring to is the fact that are the people who get severe illness or those who receive a bigger inoculum of virus. I don't think it's so clear cut. There may be some relationship, but it's also a host factor as well. Clearly age is a factor, clearly comorbidities is a factor. Also, there's a group at Rockefeller University in New York led by Jean-Laurent Casanova who's shown that certain individuals have defects in their ability to make type 1 interferon, and they're very susceptible to the virus. I think it's a combination. I think virus inoculum, amount of virus you get has an effect, and I think host responses. There's one interesting paper that I'd like to quote, but it hasn't gotten a lot of press or attention. It was done by a group out of Croatia that really looked at this and showed that the mortality rate of COVID-19 is higher in cold climates. And one hypothesis around this, and this David Rubin at Children's Hospital Philadelphia and Penn have said this, that his hypothesis is that in the cold climates, virus survives better, so that people are getting infected with a bigger inoculum. So if that's true, that's another reason why mortality rates will be high pretty soon.
Getting back to immunity again. So I was reading the other day that I believe, and it's probably not the accurate name of the place, but La Jolla Vaccine Institute had presented some results, again in the lay press, that immunity seems to be long-lasting, and in their words, might even last years, that they were finding that at least 5 or more months out, that there was still some evidence, or strong evidence, of immunity. They haven't put it in a peer-reviewed paper that I'm aware of yet, but...
Yeah, no, I saw that, and I agree with it. Again, this goes back to the original SARS. That was true for SARS when some people had antibodies, and for 12 years afterwards when they were looking. And I think that will turn out to be for a majority of individuals, but there will be a subset that won't. And to me, it looks as though the more severe the illness you had, the higher the virus neutralizing antibodies, the more robust the immune response, the less likely you'll be susceptible to reinfection. If you had asymptomatic infection, you had lower levels of virus neutralizing antibody and maybe more susceptible to reinfection. But even then, you still have memory T cells. So we haven't really sorted it out, even among the asymptomatic individuals. There's probably a group that is still going to have long-lasting protective immunity, and another group that may be susceptible to reinfection. I think that's how it's going to sort out.
Which isn't all from many other viruses.
Right.
Here's a vaccine cold chain question. With vaccines being required to be kept really cold, and to my knowledge, it's mainly Pfizer vaccine in this case, how will that affect distribution and being actually able to get people vaccinated?
Yeah, so each vaccine is unique. So ours, for instance, requires simple refrigeration. So just like any vaccine, you would get at HEB or Kroger's or anywhere else that adults get their vaccine. Probably the same is true of the 2 adenovirus-based vaccines from AstraZeneca, Oxford, and J&J if they get up. The Moderna vaccine is somewhere in between. It does require minus 20-degree freezer storage, which is basically the temperature of a household freezer. So it means the pharmacy will have to keep a freezer. But now they've been able to show that it's still stable for a month at refrigeration temperatures. So I think that will be doable. I think the toughest one's going to be the Pfizer-BioNTech vaccine, which has to be stored at minus 94 degrees Fahrenheit, deep freeze, and it's only stable for 24 hours at refrigeration temperature. So that one is going to be more problematic to get the way adults usually get it. So, but I know, McKesson has been contracted to do the distribution. There's a 4-star military general, Gus Perna, who's taking leadership on this. So I think they'll solve it. And remember, this is the first time we've had an RNA vaccine. I think one of the things that you're seeing now is a pretty massive R&D effort to improve on stability, so we can ultimately have it all mRNA vaccines at refrigeration temperatures, and who knows, maybe even one day at room temperature.
I mean, I know that Pfizer and Moderna, they're competing, I think it's fair to say, and rush to get this stuff out. But there might be a place that I'd like to know your thoughts for sort of a dual strategy, so that the Pfizer vaccine, which requires these ultra-low freezers, might be better delivered in places that has access to those freezers. But if you're out in rural areas, for example, where it might not be that easy.
Yeah, I've heard that as well. And I think right now, it's not even that people are really confused. I think everybody realizes this is a public health emergency, and we recognize that no one company has the ability to manufacture enough vaccine even for the country, much less the world. And so that's why you're seeing this, I call it a vaccine ecosystem that's unfolding. So you get these 4 that are coming into the US, you get vaccines like ours, the Chinese, the Russians. I mean, ultimately, we're going to be looking at having to vaccinate the entire adult population of the world. I don't know, 3-4 billion people, and maybe the entire planet, so entire human planet. So we're looking at, how do we get that level of vaccine out to people? And that means getting multiple players. And I think that's what you're looking at. So for instance, you're seeing all sorts of interesting relationships happening. So AstraZeneca Oxford is partnered with Serum Institute of India in Pune, West India. They're the largest producers among the largest producers of vaccines in the world. They make a lot of the vaccines for Africa. So we're seeing sort of arrangements like that as well.
So is there then a coordinated effort, or at least are the different vaccine companies talking to each other to discuss this sort of coordinated approach to vaccination, knowing that one single vaccine or one vaccine company may be able to meet all the demand?
Well, hopefully that is happening at Operation Warp Speed. With Onso Slaoui and Gus Perna and those individuals. The problem is, Operation Warp Speed has done a good job in terms of scientific rigor and integrity of the trials. They have no communication strategy with the American people. They've left all the communications to the pharma CEOs, who really bungled that message quite a bit. So I think we're going to have some issues around communication, at least for the next few weeks.
Okay. Well, we only have a few minutes left. We've got a couple more questions. What's your opinion on chronic health issues for recovered patients?
Yeah, it looks, and I don't think we really know why, but a subset of individuals seems to have ongoing pulmonary disease. This is a vascular disease more than anything else. I mean, the thing I worried about if I get COVID is not just the lung disease, it's the fact that this causes thrombotic events, so coronary artery thrombosis leading to heart attacks, sudden deaths, pulmonary emboli leading to sudden deaths, strokes, and that has been really devastating. There's also a lot of chronic neurologic complications. We hear about brain fog and cognitive deficits and depression, and just another reason why you want to do everything you can to avoid getting COVID-19.
Yeah, and I think that's a very important point. One of the things we deal with, I know at Baylor we deal with it as well, is determining when a frontline healthcare worker is ready to come back. I mean, everybody focuses on the symptom-based return to work strategy, 10 days, and their afebrile 24 hours are markedly improved. But a lot of folks, that's just a minimum, right? I mean, there are a lot of people that aren't ready to come back in 10 days, not because they're contagious, but because they're still not well enough to come back.
That's right. And some people, may have gone permanent disability because of COVID-19. I mean, remember the full disease toll and mental health burden of this virus. It's going to take us years to understand, and it's going to be massive. I mean, it is going to have a massive impact on the American people. And the fact that, we couldn't organize ourselves, especially in the red states, to control this infection, it's going to leave an awful legacy for years to come.
agree. So I know we're jumping back and forth. So Pfizer is now selected a few states, I believe it's 4 states, to test, I guess, its distribution system, and Texas is one of those states. Can you give us any updates or how that's going? I know it's only been in the last 48 hours, but
Well, I've been speaking to the Houston Health Department, I think, and in our area, Houston, we've got both Houston Health Department and Harris County Health Department. I think the Houston Health Department is going to take a leadership role for what's in Houston, and then Harris County will do all the bits outside of Houston. That's still Harris County. And they're working on plans both for this pilot program and as well as the full distribution that's being talked about.
so when do you see the first vaccines actually being administered outside of the clinical trial here in Texas?
I think once the EU get the green light in the EUA, potentially, I didn't think it was going to happen, but I think it could happen before the end of the year. We could even start seeing it in December. I think that's a possibility.
Let's finish up by talking a little bit more about your vaccine. So some people call it the bread vaccine, right? The yeast vaccine, similar to hepatitis B, as you were saying. So the advantage is, if I heard you correctly from what I read, it's low cost, less than $1 a day. $1 a dose. It can be at room temperature.
Probably refrigeration.
Right, and therefore, and what about transporting it? You transport it refrigerated, so that might make it especially attractive for the areas that you've done so much work in, which is the developing world, right?
That's right. So, we're now testing it, and we announced on Mondays we're testing it in 5 sites in India. Hopefully, even though it took us longer to get into the clinic because you can make a piece of RNA faster than you can make a recombinant protein, we were able to make it pretty quickly because we've been working on coronaviruses for 10 years. We hope we can move faster through clinical trials. And the reason I say that is when you have a brand new technology, anytime you get a bump in the road, if there's a adverse event and it slows you down because you want to make certain it's not due to the fact this is a new technology. I think people have more of a comfort level with the recombinant protein because we've been doing that for 40 years through the hepatitis B vaccine. So even though we're not as quick first leg of the journey, I think we can speed up quite a bit. So my hope is we won't be too far behind the others so that by the middle of next year, we'll be vaccinating large populations. The unknown is whether we work to try to get it into the U.S. and whether there's still going to be the need. One possibility is if some of the other vaccines in Operation Warp Speed don't give you a very durable immune response, ours might be able to come in as a boost. That's a possibility. So it's really a matter of whether we can get the right partners that want to work with us for a U.S. strategy. I mean, we worked with India because they were really interested and they've got a great track record, and so we went with it. But we're also talking to places like Indonesia and places in the Middle East, and we're also trying to work out a strategy for Latin America because Latin America is really on the outside looking in terms of having access to vaccines. So we're looking for a Latin American strategy, talking to Mexico, Panama. I mean, this is what I do. I mean, I wake up at 4 or 5 in the morning and on Zoom calls all day and night, and then in between, doing the various CNN, MSNBC, BBC stuff, and it's just a very odd existence right now. But it feels good to be making a difference.
And you certainly will. Are the 5 sites, India sites, is that a phase 3 already?
No, this is right now just phase 1, and hopefully we'll move pretty quickly through phase 2 and 3.
Well, on that note, look, I really wanted to thank you. It's been an honor to moderate this. I think it came out pretty good, as moderated sessions often do, because of the interest that it generates. And you're so visible and clearly so committed to what I think is it's a pandemic of our era. It's the plague of our era.
Yeah, I mean, it feels, in some ways it feels good. I mean, I got my MD and PhD to use science to make the world. You did too, right? I mean, this is why we do this. And so in some ways, it's a privilege to be able to have that opportunity to make a difference.
Well, again, thank you so much.
Ability and Emergency Management at MD Anderson Cancer Center today. And also joining him is Miss Linette Leadon, who is the Director of the Environmental Health and Safety, Sustainability and Emergency Management Department at UT-MD Anderson Cancer Center. And today they will be speaking on COVID-19 response, including ensuring patient, visitor, and employee safety. And I'm going to let you guys just give a short summary. You want to introduce any more about yourselves or what you're talking about? Go ahead.
Thanks, Michelle. Good morning, everybody. Thanks for having us. It was a privilege to hear Dr. Hotez, and it's a privilege to be here today. We have, and Linette is one of my proteges, which means I get to bring her along with me, and she's going to help me present today. So I'm glad that she was able to make it today to help me out. It's always a privilege to come present to this council. So thank you for having us. Before I get started, there's some things we can share. There's some things we can't share. But questions like, did we follow CDC guidelines? Yes, and we did. And in some ways, we exceeded CDC guidelines. So I'll put that out there now. I'm going to go through our story a little bit. Just a quick bit about MD Anderson, a little bit about our department. You'll see that mixed in here. I'm going to talk about novel events and routine emergencies and why this was a novel event for us and for a lot of others versus a routine emergency. A little bit about our preparation, the role of our team, why it was important for us to really partner with supply chain and infection control during this event. Perspectives from the front line. Linette's going to share some of her experiences and some of the things that she was involved in. And then just a quick slide about what we think some of the future topics may be post-COVID. So just a little bit about MD Anderson. We're just over 20,000 employees. I'm going to talk a little bit about that. We have, educational appointees, faculty members, volunteers. We are at about 30% at least working from home right now, and that was part of our implementation plan. I'll get into that a little bit more. I'm going to go over our locations and where we're located across the Houston area. We have the medical center locations along Fannin and Holcomb in that corner there. We also have expanded to the Woodlands, to West Houston. We have partnerships with LBJ. We have patients that we bring in from LBJ through that partnership. And we have some other partnerships across the world, all the way from Phoenix to, I think, Spain. And we've got stuff in New Jersey too. So we've got partnerships across the world. A little bit about our department at MD Anderson. We have 175 employees in the department. Now, when you, as some of you know, when you're in an environmental health and safety world and they think you're doing a good job, they think you can take on a few more things. So that's why we've kind of grown over the last few years. But you can see all the basics there that we had, everything from radiation safety to the emergency planning, industrial hygiene. Right now in our department, we also have the building automation system department, a warehouse that we're overseeing that supplies a lot of materials to the campus, primarily to housekeeping and facilities. And they also, we have a cabinet shop, which has been so critical, and you'll see some of that when we play our video of how they've helped during this COVID time. Average age in the department, somewhere around 45 years old. We've got baby boomers, Generation Z. We are not regulated by OSHA. Sometimes that's forgotten and we have to remind ourselves too, but we do follow a lot of their practices. And that's due to our state agency, part of being in the state of Texas. Our recordable injury rate is 1.18, and that has dropped. We were well on our way to getting it down. It was running around 1.7, and then as more employees started working from home, we scaled back operations. It's gone even lower, and we have other metrics like that we think due to some changes in operation we'll say improved due to that. So sort of a silver lining in all this things we've had to manage over the past 9 months or so. Part of our as being a hospital, we have to comply with Joint Commission, and they have an emergency management chapter that we follow. We do everything involved with that's required for that. And then the Centers for CMS has been on our campus the last 2 years reviewing our operations, and they also have a condition of participation called emergency preparedness that mirrors that Joint Commission chapter, and both of those requirements put a lot of, require a lot of effort from our department to keep up with that. And so I share that because this is sort of the ABCs and nuts and bolts of emergency management. But if we think about, COVID and epidemics and pandemics, and what we're required to do as part of those chapters is do a hazard vulnerability assessment. And over the years, we've had, some events. We've had Ebola, we've had, swine flu, Zika virus, et cetera. And so that's risen up in our hazard vulnerability assessment for the campus over the years. And it's just something we have to remember. This is not new. It may be a new virus, it's a novel virus, but from a worldwide history perspective, this is something we should always be aware of. And the things we're doing now, the cleaning, the hand washing, the special sanitizing are things we probably should be doing anyway. And we just, have gotten a little relaxed over the years. So we believe this novel response required a novel structure. So I'm going to talk a little bit about the back and forth between what standard emergency response is and incident command, and then what we did. So we decided to reserve the routine structure of our emergency response for routine events like utility outages, hurricanes, and floods, and we had a few of those over the last year. We established several teams to look at access to the campus, reducing operations and education. We closed research operations in approximately 48 hours, and that was a huge endeavor. Linette was involved in that. I think we started on a Saturday, and by Monday or Tuesday, research operations, everyone was working from home, and they weren't back in their labs. We had to isolate the research component from the healthcare component as much as possible. We established a restricted supplies team to look at, security, inventory, including existing inventory, massive amounts of donations, and new sources of purchasing PPE and other supplies. We had to look at distribution, how we were distributing items, and then monitoring our inventories. And we've done that in conjunction a lot with the Texas Medical Center and our neighboring institutions to check in with each other and see how we're doing. But the monitoring inventories is ongoing and continues to this day. A little bit of a comparison of what I call a novel crisis versus routine emergency. And this comes from a chapter in a book. The chapter is called High Performance in Emergencies by Dutch Leonard and Arne Howitt. They're out of Harvard at the Kennedy School. But if you look at a routine emergency, there's an org structure, it's established, it's hierarchical. When you get into a novel event, you want to flatten that and look at creativity. You need to have some hierarchy for implementation, but you need to be able to be a little more creative. Routine, you have pre-written plans. They're available, they're tested, you do drills on them. And for this novel event, a lot of things had to be created. We had some things in place, but we had to do a lot of new things. And a routine emergency, sometimes you can see it from space. You can see hurricanes from space. But a novel event, you're definitely going to be able to see from space. So, and then, examples of a routine event, obviously, are car wreck. Everybody shows up, they have their role, they know what to do. Same for hurricanes, for us at the hospital and us along the Gulf Coast, and fires, there's a routine response. And this virus that disrupts our whole world is just, it's been novel. We've had a lot of things that we've done before, but a lot of new things, and everything was amplified. So because this pandemic was in our hazard vulnerability assessment, in December 16th, 2019, we did an incident command exercise called the Snowball Virus. And you can see the basic scenario that we did for our incident command team. We had about 180 people in the room when we could still get in the room. We ran through this scenario. We took the institution down to about 45% staffing, and everyone had to work through scenarios of how they would manage that, when we would start canceling operations, scaling back just operations across. We just probably did it different when the real thing happened, February and March. We also, just a reminder, MD Anderson has the highest density of immunocompromised patients. So if you look at the standard incident command system structure, we have this in place. We decided to reserve this for all these other routine emergencies like Hurricane Laura. And even in February, right as we started planning for COVID, the city of Houston lost a major supply of water, and we were down for a couple of days over a weekend. So if you look at the textbook version of this, and a lot of people really think you have to go textbook on this incident command system, we've had to modify it to fit our organization, our institution, because it's really a challenge for healthcare organizations, especially big organizations that have a lot of committees and a lot of org structures, to go from their day-to-day routine to switch focus. So this is our modified incident command. It's scalable. We can go different sizes, and we stood this up probably late January, February. We started raising our alert level to level 2, and our highest level is level 4. We've remained at level 2 since the event started. And we pushed this to the side a little bit to hold on to it for other emergencies. And so you can see what we had to have the incident command process in place and handle COVID with a whole nother structure that consisted of a lot of creative committees and solving problems, things we hadn't done before. Now I think that if we had another one of these, it would be let's open the box and break out those tools we use for COVID and see how many of them will fit for whatever comes next at us from a virus perspective. We did lose power in the Woodlands in August, and you notice the dates the same as Hurricane Laura. Our power supplier for the Woodlands facility is in Louisiana. So while we were glad that we didn't have to manage through Laura, and we were very fortunate based on some of the studies we've been looking at, it did knock out the power to our building for a couple of days because of where that power supplier is. So something we probably missed in our risk assessment that we're more aware of now. So a little bit about our response to COVID-19 and what that looked like. Like I said, we did activate to level 2, then we shifted to more of a novel approach. Some of the goals that were established by leadership at the institution was protect our unique immunocompromised patients, ensure the health of our workforce, minimize the impact on our, our local community, and being good stewards of our PPE supply. We couldn't give everybody an N95, even though everybody wanted an N95. We really had to set some expectations on when and where we needed to use those. Same for other PPE, and a lot of protocols and algorithms were developed on when and where they'd be used. We set expectations on masks, on social distancing and hand washing, and that has been the mantra for the institution to this day. And I think even as we do get a vaccine, at least at MD Anderson for a while, you can still expect those 3 to be in place until we really see the outcome of the vaccine and how it would impact our patients. Communication was critical. We went from a routine daily 8 a.m. update to a large group of leaders at the institution. Very transparent communication when things came up. It was very well communicated. You could probably find Dr. Peter Pisters on YouTube, on Twitter, and his various communications out to our patients, our employees, our board of visitors, everything. So very well done, great leadership team, and very important to maintain that communication of what's going on, what's changing, because things changed a lot in the last 9 months. We did establish teams to address various areas, including access, scaling back operations, restricted supplies, and telehealth. And telehealth has come to the world. Some of you might have on this call, or family members might have already had a doctor's appointment over Zoom or something like that. That was always in our strategy, but it got sped up during this event, and I think we've been able to make it happen. There's still a lot of legal issues around telehealth, insurance. What are the rules if I'm in Houston, but I'm telehealthing with a patient in Indiana or something like that. So there's a lot of rules that they're still working through, but definitely we're able to do that through some of the emergency authorizations. So a lot of you have probably seen and studied this chart on the hierarchy of controls and how we applied that at the institution. And I've used this chart a few times during presentations at MD Anderson. Social distancing, we want to eliminate or physically remove the hazard And so, you know, a lot of conversations about, do you really need to go into the room? Can we do this different? Can our social workers that talk to patients do it over an iPad rather than entering the room where we have a positive patient? Negative airflow, the facilities team did a great job converting several floors in one of our buildings to negative airflow. We also helped them procure numerous HEPA filters, you know, the R2D2 sized HEPA filters, to add additional air turns in the room to help with the engineering controls in place. And then obviously limiting faculty, staff, and patient rooms, really deciding who needs to go in there. Early on, the nurses carried a really heavy load, and when we say healthcare heroes, you know, you have to put them at the top of the list, because, you know, we weren't having housekeepers go into the room. We were having nurses deliver the food to the room. The food might get delivered to the floor, but then the nurses took it from there. Same for housekeeping. We've since been able to transition, and as we've learned more and been able to manage our PPE appropriately, we've been able to do that. And then personal protective equipment, obviously last line of defense, but in healthcare, it's difficult to remove all these other things or enhance all these other things and not have PPE, because, you know, the source is the patient and or your fellow employee. So a lot of good work, and it really fit into this hierarchy of controls to help us out. So I want to pause here for a minute and just look at the faces you see here, all of our healthcare heroes, but also the various PPE they're wearing, from the face shields to the masks. We were very rigorous in what we would allow on campus. We were very concerned about our N95 supply, so we did implement PAPRs. Because we had a supply of PAPRs, we did implement half faces for certain situations, and we did create an algorithm for fit testing, because we had several models of N95s on campus. And so if you only have X number of N95s and you fit test, you know, 8,000 people to that, you're going to run out real quick. So we had to go through and decide what do we have the most of. And we've done nonstop fit testing since March. We've scaled back to Monday through Thursday, all day, and then a few evening shifts. The face shields have been interesting. We did have a group that worked with us on, you know, 3D printing face shields. We got a lot of sources for face shields. It's been a great learning exercise through this whole thing. And then once we got the face shields, everybody wanted to know how we could recycle them, and that just hasn't happened. I want to talk a little bit about the Fda Emergency Use Authorization that was issued in March around PPE to help with shortages. So what this did for us is it said you can use non-powered reusable respirators such as the half-face, full-face respirators approved by NIOSH. And then you could use PAPRs approved by NIOSH. And then you could use NIOSH-approved half and full-face respirators past shelf life with multiple exceptions, no damage, good storage, etc. And any above that has been decontaminated correctly with an authorized decontamination system. So we went through all of this, and we did have PAPRs on campus. We still have PAPRs on campus. We've had a lot of people that have learned a lot about PAPRs because we weren't a big PAPR user, even though we had them on campus. And the other thing this emergency use authorization did is there was a release of a long list of N95s and other products made that we don't normally have on campus that are made, you know, across the world. So what we did was we set up a process with employee health, with sourcing and infection control. Infection control primarily reviewed gloves and gowns, and we primarily reviewed the respirators. So a lot of education about the different types of respirators that we had to share with the campus, educating them on PAPRs. We have a whole video on how to use a PAPR now. But there's a lot that goes along with this. And as you all know, sometimes the simplest is the best with just an N95, because there's a lot that goes into managing a PAPR, a lot of education, charging batteries, keeping things clean, and so forth. So when we partnered with infection control and supply chain, hand sanitizer, we had a lot of offers. We've bought hand sanitizer from our normal suppliers, but then we got put on what's called allocation. So when you're put on allocation, that means that you get what you've been normally ordering every month for forever, and they wouldn't really increase that. So when we started using more hand sanitizer, we had to go outside and look at other sources. Gowns, we looked at gowns from a lot of different places that we haven't used them before. And infection control, we partnered with them quite a bit on the gowns and testing them out to make sure they fit our criteria. Same for gloves, both EH&S and infection control would review gloves to make sure they were appropriate, because we had a lot of sources coming at us from different directions wanting to offer us items that we had never used before. I'm going to linger here a little bit on respirators. So we would get in respirators to test from all kinds of sources. And you can see here on the left in my image of all the ones that didn't pass multiple fit tests to see if we would allow them on campus. You can see, the 3 that we still are using, although that bottom one in turquoise, I think, is a BYD, and we've had some mixed results with that one. And then you can see here that we like these, but they're 20 weeks out on getting them on campus. And then masks, just the surgical mask that when you come on campus, we give you a surgical mask and making sure it meets the FDA requirements that infection control was looking for. Disinfectant, we actually had a lab on campus start making disinfectant for us because, just for surface cleaning and that type of thing, we were running short and we needed to have other sources. And it was just an amazing, heroic effort by a group that doesn't normally make chemicals. We went through the whole MSDS process and everything internally to say it was okay to use. So a lot of learning. Doug Rush sent me his presentation, and we know that little dot in the circle. There's a lot that we learned and a lot that we educated people on as well. So I'm going to turn it over to Linette, who has some different perspectives than I experienced. So Linette, I'm going to go to the next slide when you're ready.
Okay, thanks, Matt. So while Matt said it, we had a lot of learning, a lot of different perspectives, and a lot of novel things happen to us in EH&S and our interactions with others around the institution. So we were asked to close approximately 2,000 labs. Why? We needed to separate them, the research from the clinical. We needed to reduce the people on site, to preserve our PPE, and to reduce the possibility of transmission. So with that being, there was a lot of planning that had to happen, and it had to happen very rapidly. Initially, discussions were we would close the labs in about 72 to 96 hours. Within about 12 hours, that decision changed to 48 hours, that it was more immediate and more pressing. So there was a lot of communication. Our communications department had to communicate to lab users, to PIs. We had to communicate to our EH&S staff because we needed staffing and feet on the ground to be able to help close these labs very rapidly. We began on a Sunday morning, and by Monday afternoon, we had completed the closure of all the labs. What else became integral for our planning is checklists. Checklists were developed for the lab users so they knew what equipment to shut down, what our expectations of them were, and from their leadership. So that's the other piece that went into this research laboratory shutdown. Clear expectations. Clear expectations for the safety of everyone, that everyone will remain safe. Expectations of the timeliness of our walkthroughs, because once the labs deemed that they were done cleaning up, getting the lab in a place where it could be dormant, then we were to walk through those labs and survey with our checklist. Documentation, documentation, documentation. What did we do? What were we going to do? What was done? And the expectation would be that these labs would be closed to on-campus people indefinitely. Next slide, Matt. So I wanted to go over our successes and some lessons learned. So our successes, it was completed in 48 hours. We had no injuries or incidents. The laboratory personnel cooperated completely. They were on site beginning Saturday, stayed all day Sunday, and we had lots of leadership support. Since this was something we'd never done before, we didn't know what to expect, how it was going to go. So definitely there were some lessons learned. One, EH&S, if we have to do this again, we're going to have to schedule appointments. To close 2,000 labs in a short period of time was very challenging for our staff. We had about 20 people on staff that were going lab by lab. But as we learned, it took a lot longer, and lab personnel were waiting for us for many hours, and we didn't have a clear schedule of when we would get to them, so we would do that different. Clear expectations for equipment. What we learned is some people unplugged items such as refrigerators and freezers. others didn't. So we had issues later where water was in different places, freezers unthawed, some samples may have been lost. We also we learned that we need to implement plans to survey the areas while dormant. So what happens is things happen in our facilities, and normally when people are in those facilities, they're calling us. They're putting in service tickets. Well, when no one's there, doesn't mean things don't happen. It just means they are unreported. So we did have to, after the labs were closed, begin to start surveying those areas to determine, do we have any pest issues? Do we have any old food or lunches left laying around? What condition are our labs in? We also need to document the process in the event of another shutdown. Be very thorough in our documentation, what we did, what worked, and what didn't. Next slide. So the labs were closed for about 3 months. So we also had to plan for a ramp up. How will we bring people back? It was decided that there would be a phased approach, and there would be criteria for opening at each phase. This criteria was developed based on community spread, what's happening with our employees, how many are positive, how many patients are we seeing. So initially, phase 1 was essential services, or those mission critical items that must be completed. During this essential service time, people were allowed to come on campus only as needed to check experiments that were already in progress or to complete tasks that affected patient care. Phase 2 began with shift work. We had 2 shifts. Everyone was screened upon entry, and you were only allowed to work either from 6 a.m. to 1 p.m. or 2 to 9 p.m. Researchers were asked to plan their research at home, do as much as at home, and only come on site to do what's necessary. We are currently in phase 3. Back up, Matt. We're currently in phase 3, and now we're allowing people to work at their staff at their discretion while being socially distant. Now you can go to the next slide. We also stood up a COVID hotline. This was to report all COVID concerns. It was to be captured in real time. It gave leadership insight into the front line. It was open to all employees. You could make a phone call or you could enter it into a SharePoint site. Anonymous reporting was allowed, and we were required to respond in 24 hours. You can go to the next slide. Back one slide, please. I wanted to share with you some of the common entries. Lots about PPE, about malfunctions in PPE and the defects of PPE, any shortages we had, and lots of concerns about masking non-compliance. Capacity limits, social distancing were also a large amount of our reports. Making sure there were socially distanced break areas. Our disinfectant use, how we were managing that stock. We had lots of concerns about signage and about the screening station. So with all of these COVID hotline entries, we also experienced lots of benefits from this COVID hotline. Next slide, please. This was the best way for leadership to be rapidly aware and resolve any issues. It improved our communication. It has improved accountability. Staff feel like they're being included. This will serve as a database for trending on where we need to work on our training deficiencies, areas where we needed to validate what we were doing, and the anonymity increased our reporting. So I'm going to turn it back over to Matt so he can talk a little bit about what we've learned as a department.
Thanks, Linette. Yeah, we learned, the opportunity here was for, EH&S professionals at our institution we were an integral role in the success of the operations, especially around PPE, supporting this hotline, supplies. Some services were scaled back and some expanded beyond our resources. So, we had to keep the fire alarm systems up to date. We had to maintain our safety. All the things we needed to do for compliance purposes, we still had to keep doing. We are on shift work right now. So Linette and I, for example, will work 3 days a week in the office and two days a week at home just to keep everybody socially distanced. We had to expand our communications on PPE requirements. We probably assumed that people knew what they needed to know, and we had to really amp up our education around PPE. Once it's out there, it's hard to pull back. So once you say, hey, yeah, this group's going to wear PAPRs, it's really hard to pull that back. So, but we didn't know a lot about our inventory. We weren't secure in where our inventory was at that early time. So we did roll things out, and once you roll them out, they're definitely hard to pull back. We had to be more agile than we've ever been before, more flexible than we've ever been before. You know, collaboration was just huge. We worked with a lot of people that we've never worked with before at the institution, and that's a plus. And then just our team orientation, keeping our team focused. I think I've done 33 department updates. Sometimes Linette will lead them. Sometimes one of my other directors will lead them. But every other Wednesday now, we have a Zoom call with about 150 people to keep them in the loop on what's going on, and just keeping the team focused. It's a different world. We don't get together and have those hallway conversations like we used to because we're not seeing each other in the hallway. A little bit about the future. You know, the institution has a goal of having, you know, working remotely 30% or more in some cases. We think continued masking is a possibility for us for a while because of our immunocompromised patient population. We do have a pandemic supply team. We stood it up after Ebola happened in Dallas, but we learned a lot where we need to improve for that supply team. That brings infection control, sourcing, pharmacy, and others together, emergency medical teams together. Changes in sourcing strategies. We had to vet a lot of sourcing opportunities that we hadn't run into before. And then design of future buildings. Do we need more negative pressure rooms than we currently have today? Will hospitals be built different from an entry perspective? One of the things we're looking at right now is how you come on campus. You know, we have a program called Welcome where we're evaluating, you know, as much touchless entry to the campus as possible. But we also want to know who's on campus, even potentially when they've left campus for safety reasons. So a lot going on around what the future buildings look like and how many buildings we'll need. There's a serious potential that because of that 30% or more working from home that we'll scale back some of our buildings, especially some of our older buildings. The building I'm in today, we may vacate in the future. So we have a quick video we'd like to share. Michelle, let me know if we don't hear the sound. We should, but
Yeah, Matt, I think we're running a little over. How long is this video?
2 minutes.
Okay, I think that's fine. We're probably not going to be able to take any questions because we're about 3 minutes over. But
would you prefer questions over the video?
It's up to you. I was going to say if people have questions, they can go ahead and start entering them into the Q&A box, and we'll see what we have. I don't have any, so if you want to go ahead and share that video. Okay. And then if there's a lot of questions, we can send those to you to get some answers that we can send out by email later.
Okay.
Okay, go ahead.
We don't have volume, Matt.
No volume? Okay. All right, Michelle, why don't we see if there's any questions from the group, and then I don't know if it's the sharing or something else that's not allowing the video to pop up.
Yeah, I am not sure.
We had it yesterday.
Okay.
Yeah.
All right. Well, if anyone has any questions, go ahead and enter those into the question and answer box, and we'll get those attended to. In the meantime, thank you. That was a very informative presentation. We also have been hierarchy of controls is just, I feel like I've seen that 1,000 times, but I think it's so important. It's so very important. So every time I see it, I think it's a great reminder to all of us. So thank you for that. And thank you for your presentation. I don't see any questions coming in. If anyone does think of anything, you can just make sure you address those to Dr. Matt and Miss Linette, and we can always get those over to them later. So I'm just going to go ahead and thank you both for your time and your presentation today, and then we're going to go ahead and get started with our next presenter.
Thank you for having us. We appreciate it.
Thank you so much. All right, Justin. So Sylvia, can you pass Justin the ball? And then Justin, if you want to go ahead and there we go, share your content. All right, well, you're getting that ready. So we have Dr. Justin Henderson from MD Anderson as well, from the Employee Assistance Program. And Dr. Henderson is a licensed professional counselor supervisor at MD Anderson as an EAP specialist. He is also an active associate minister and the director of counseling services at Anatoch Missionary Baptist Church in Beaumont. And today he's going to be talking to us about a cognitive behavioral approach to everyday living with COVID-19. So go ahead, Justin. Thank you.
Thank you. First and foremost, let me say thank you all for the invitation to share with you on today. Anytime I get the opportunity to talk about something that I'm very passionate about, I really excited, right? So hopefully something will be said today to help you, especially as we go through not just COVID, but several stressors that's going on in our society today. Again, my name is Dr. Justin Henderson with the Employee Assistance Program at MD Anderson Cancer Center. So before we start, I want to say that I'm going to use a cognitive behavioral approach to talking about the different stressors and the different things that many of us have been experiencing since the pandemic has started. Many people, for whatever reasons, think that they are invincible from experience mental health related issues. And what I like to teach people is that any and everybody can be impacted at any and every point of your life, depending on what's going on by a mental health related issue. And so to make sure that we don't go off the deep end with regard to our mental health, I'm going to give you some strategies, some practical, concrete strategies today to be able to assist you. Okay? So I want you to look at the right side of your screen here, and this is Maslow's hierarchy of needs. You probably remember this when you were in school. And so Maslow came up with this theoretical approach that says, guess what? As human beings, we all have basic needs that need to be tended to, right, in order for us to thrive. And he says when those needs are not met, then we fail to thrive as human beings. And so the chart here is actually read from the bottom up. Okay, and so it starts at the bottom where it says, you know, human beings need to have their physiological needs met. That's the first thing that needs to be met in order for them to truly thrive. So we need to have food, air, water, shelter, clothing, sleep, so forth and so on. And then it says once that is met, you can go to the next step where you talk about another foundational need for human beings is safety and security. So their health, employment, property, family, stability. And then it keeps going to something like love and belongingness. We need friendship, we need family, we need intimacy, we need connection, so forth and so on. Watch this. Since the pandemic has started, would you say that for many individuals, these three basic sets of needs here at the bottom have been directly impacted? Right? Either by you, this has been impacted for you, or someone that you know. When you talk about individuals that have lost their shelter, right? I was sitting here looking at the news the other day where I saw a young man, had to be maybe in his early 30s, with his wife and his daughter. And the sheriff had showed up to their house here in Houston and was telling them they had to leave. And they were putting their stuff out because he simply did not have the money. You know anyone like that? Yeah, I'm pretty sure some of you do. Even let's go to the second level here, safety and security. How many people have been worried about their employment? Worried about, you know, job security, worried about their health. Will I catch this virus? Do I know someone who has this virus? I'm just worried about my parents. I'm worried about my children. I'm worried about our stability as we continue to go through this, right? And then we have this thing called social distancing, right? Which I really wish they would change that term. But we're not able to see our friends. We're having to find creative ways to connect with our families. And one of the things I know to be true is that love and belongingness is very important. It is so important that, you know, when we have children, for those of you who have children recently, you will notice that even in the hospital, Once that child is born, they tell the parents to take off their tops, and they take this little naked baby, and they tell the parents, now, I want you to hold this baby or put this baby close to your chest. You need to have skin-to-skin contact, right? Because we've discovered that that connection is very important for human development. And so, how many of these things have been impacted by you? Impacted by people that you know? And so people are struggling at this particular point because their basic needs are not being met. Now, let's go to the left side of the screen. As human beings, life happens, right? We experience traumatic things such as divorce or unemployment, death, cancer, rejection. I live here in Houston, so hurricanes, right? War. And now we've been introduced with something, this huge thing that has taken place that many individuals in our society today have never experienced before, and that is the pandemic. If anyone that's on the line was alive in 1918, I need to talk to you after this, because I have some questions about what you did with the Spanish flu pandemic, right? So it happens to everyone. And because life happens to everyone on this planet, right? I have individuals that come into my office that fall into two categories. One of the two categories. And here are those two categories. There's no other categories. They either fall into one of these two categories. I have individuals who come into my office who can cope, and then I have those who come into my office who cannot cope. And some can cope during some things, and some can cope during other things. And then sometimes they experience situations in life they simply have difficulties getting through that. My question for all of you on the presentation today is, which one of these categories are you falling into? We're heading into the 9th month of dealing with this. So which one of these categories are you falling into? And give yourself an honest assessment. So I want you to look at this here. When we look at this, I don't want you to look at it as, Dr. Henderson is saying, I have one of these mental disorders. No. I actually don't even want you to look at the left side of this. I really want you to look at the right side of the screen. And these are just signs and symptoms. And these signs or symptoms doesn't mean you have a mental disorder. It just means that the stress of whatever it is that you're dealing with may be starting to impact you, which can lead you to a mental disorder, right? So look at some of these signs and symptoms that a lot of people are reporting that they're experiencing during this time. Overeating or undereating. I found myself the other day going to the refrigerator several times. Sometimes I was going to the refrigerator and I was just standing there. I wasn't even taking anything out. I was just looking, right? And then there were times I was going and the stuff that I was getting, nothing was healthy for me. I was just stress eating, right? How many of you are doing that? Isolation and avoidance, decreased energy, weight gain or weight loss. Anybody gained a few pounds since this has started? Anybody lost any weight? Feeling overwhelmed, tearful, argumentative. And this is something that I'm going to talk about. Being argumentative and irritable during this time. Those are common signs and symptoms that people are reporting. How many of you have significant others at home and you and or children, and you realize you're feeling a little bit more irritable with them, or you find yourselves engaging in a little bit more arguments throughout the house, right? Feeling guilty, fear, worrying what's going to happen next. Always having these thoughts go through your mind. Sleep disturbance. Either I'm having nightmares, or I just simply cannot go to sleep, or I'm waking up several times, or I'm not getting the full 8 hours of sleep that I may typically get, right? Being hyper vigilant, being hypersensitive to everything that's around you. And here's one of the number one that I'm hearing right now. I'm just not motivated. I'm tired. I just don't have the energy, the push to do anything that I used to do. These signs and symptoms are very important for you to pay attention to, because if you're experiencing them, even if it's just a little bit, the question becomes, what are you doing about it? Okay? Watch this. Even as a psychologist, even with all of this information that I hold with regard to mental health, and knowing I too have been impacted by this, not just by the coronavirus, but when you talk about the racial injustice issues that's popping up, when you talk about the election that has popped up, all of those things have contributed to my stress. And as a result of it, I too felt myself feeling a little bit more irritable, losing energy. And I had to recognize that first and foremost, and then I had to come up with a plan of how I was going to address it. So my question for you guys is, what plan do you have to address the stress that you've been experiencing, or the weight of the stress that you've been experiencing as a result of the societal issues that's been going on? If you don't have a plan, don't worry, I'm going to help you today. All right? So here's one of the first strategies I want to teach you. This one is called the cognitive model. It becomes important for you to look at this model because it's going to make a lot of sense to you, and it's going to challenge a lot of you on the way that you see the world and how you handle things in your life, right? First and foremost, I want you to know there are three main parts to who you are as an individual: thoughts, feelings, and actions. I want you to say that. Thoughts, feelings, and actions, right? You cannot have one without the other. The truth of the matter is, at the end of the day, you control all three of these elements, okay? If you change one, you change the whole system. Here's another thought that I want to throw out there to you. I want to put this in your gumbo pot while I'm standing over it, okay? You control all three of these elements of yourself. That means that you can never say, this cognitive behavioral model says you can never say that someone made me think this. She made me think this, or he made me think these thoughts, and that's the reason why this is happening to me. Absolutely not. Individuals can influence, or situations can influence your thoughts, but at the end of the day, you choose which thoughts to entertain. That means you can't say someone made you feel a certain way. You know what? The way she talked to me made me feel this way, and so that's why I'm feeling the way that I'm feeling right now, so forth and so on. That is absolutely not true. Someone or a situation can influence what emotions you choose, but that's the key word. You choose whichever emotion that you're going to entertain at that moment in time. Behaviors. You can never say someone made you do something or someone made you act a certain way. Again, just like thoughts and feelings, at the end of the day, you choose which behaviors you're going to display. Okay? And I know that's probably hard for some of you to accept, but at the end of the day, it is absolutely 100% true. So going forward, what we need to do is, in coming up with a plan, the strategies I'm going to give you, which are going to fall into each one of those categories. I'm going to give you something that can fall into that thought category, that emotions category, and the behavioral category. Remember, if you can pull out something in one of those categories and just do it, you will change that whole dynamic. It will shift if you just do one thing, okay? So the strategies I'm going to teach you will correct cognitive distortions and reduce emotional distress. And overall, it would just simply help you to cope effectively. So here's one of the strategies I want you to take note of, all right? This is the control cycle, right? This idea of what is within my control. Many people normally sit in a state of homeostasis, which just is a big fancy word for saying balance, right? Many of us go through our day-to-day lives within this element of balance. But what tends to happen is that when we have stressors that attack us at times within our lives, it throws that balance out of place. And whenever that balance is out of place, this element of control comes into play. But here's where we mess up as individuals. We tend to focus more on the things that we cannot do anything about rather than the stuff we really do control in our day-to-day lives and or in that specific situation, right? So watch this. Within this pandemic, I can't do anything about this pandemic. I want it to go away. I wish it would go away yesterday, right? I want all of this to go away so that my life can get back to normal. I can go back to restaurants and sit down and I could go back to the movies, so forth and so on. But I can't do anything about that. And so it would be ridiculous for me to put all of my focus on something I cannot do or handle right now, right? Rather than focusing on, okay, in the midst of this pandemic, what can I What can I do to help me to coast through this, to help me feel better through this? Even though this situation is going on, what can I do? I can go for walks. I can, spend more time with my family. I can focus more on some of these things that I haven't done that I know I need to do now, so forth and so on. Okay, so switching that to the things that you can control, it brings you back into balance, right? Because many times when we're focusing on things that we cannot control, we're just frustrating ourselves. The brain doesn't know what to do with that because it knows that it cannot deal with that. It has no answer for these things that you're dealing with that it simply cannot have any control over. Okay, so focusing more on the things that you can control. Here's another a tip that I have for you. Strategy. Information diet. Be careful with what you feed yourself on a day-to-day basis. You know what my grandmother used to say, God rest her soul? She used to say, baby, you have to watch what you allow other people to put in you, because what you allow other people to put in you, eventually you will become, right? And so we have to be careful with what we're taking in on a day-to-day basis. What I find is that a lot of people have been, especially with the news and with the pandemic and with all of the stuff that's going on as far as the voting and the election, we're watching the news and we're on social media all of the time. So we're watching either CNN, we're watching Fox News, we're watching ABC, NBC, all of this stuff all day long. We're getting online, we're on Facebook, we're on Instagram, and that is too much. We have to start limiting that because your brain will be influenced by that. That is depositing a whole lot of negative energy in you that you really don't need right now. So put a cap on that. So limit that to where you say, you know what, when I wake up in the morning, I'm going to watch the news. It doesn't change that much throughout the day, right? So you can wait till the evening time and you can say, oh, let me see something. Let's see if they have any updates or anything, and then put that away. Do not look at the news and be on social media looking at things and absorbing all of this negative energy all day. I have a friend who was really angry, and she called me the other day. She was like, I'm so mad today, and I'm just not in the mood. And I'm like, well, what have you been doing today? She told me she was on Facebook and she saw some negative post and she just felt the need to comment on it, and somebody commented on hers and they got into an argument on Facebook. Who needs all of that? Please give yourself an information diet. Find something else to fill yourself. Read a book or call a friend or whatever, but fill yourself with more positive than negative. Here is another one that I actually use even before the pandemic. This strategy is called thought replacement. And you can read this if you want, but let me go ahead and explain it to you real simply. Thought replacement says this, that many times you, if you're feeling a negative emotion or presenting negative behaviors, it is because you're holding these negative thoughts. And many times the negative thoughts that's influencing your emotions and behaviors that you're holding on to, many times if you really evaluate them, you will discover that they are not 100% accurate. So to help you to switch that thought into a more accurate, positive thought, it becomes important for you to identify the negative thought that you may be holding on to at a moment in time and investigate it. Just see, is this thought that I'm holding on to 100% true? Is it 100% accurate? And then if it's not, you change it. I can give you an example of what that looks like. I had an employee at MD Anderson to come into my office a little while ago, and she was saying that she was feeling really sad because she was holding on to this thought that she was not a good wife and she was not a good mother. And she said, I've been having some issues keeping up with everything since the pandemic has started. And I felt like I've neglected my children. I haven't really been cooking and tending to their schoolwork like I started off. And my husband is like, I haven't been in the mood to really spend time with him and all these things. And I've noticed this distance. So I just feel like I'm becoming a really bad mother and wife. So I said, well, what evidence do you have? So we went through a few things. Come to find out, she had very few examples that she was a bad mother and a bad wife. She was just saying, the things that I said and the stuff that has happened since the pandemic. But what she discovered is that, she really did care for her family. Things kind of changed a little bit, but she was really trying to make sure she stayed connected and making sure that her role as a mother and A wife was really being fulfilled. So we really went through some things. Her husband never told her anything negative. Her children never told her anything. She just came up with this in her head. So after evaluating that, she came up with a more accurate thought where she said, you know what? This pandemic has changed a lot of things in my life, but I'm still doing the best I can as a mother and as a wife. And that made her feel better. That was 100% accurate for her. She took it, she ran with it, and all of those negative thoughts, emotions, and feelings and behaviors went away because she had to kind of work through that. She was telling herself something that was false. That can go with anything. If you're holding on to negative thoughts through this, go investigate that thought. And if that thought does not have the evidence to support it, it becomes your responsibility not to live in fiction, but to live in truth and reality. Change it, make it more accurate, and keep going. Journaling becomes something that's really good through this time. Get you a journal. And I'm not talking about sit down and talk about like when you were children, you know, who you like and all this other type of stuff at work and all that. No. Journal. I want you to specifically just do a little paragraph of your thoughts, your feelings, and any behaviors that you had that day. Explore, talk about it. I don't care what you say, as long as the end of your journal entry, you do this. Implement 3 things that you're grateful for. What are 3 things that you're grateful for? I actually do this on a daily basis. And what I find that when I take myself out of work mode, when I take myself out of worry mode, and I really sit down and say, hey, what are 3 things that you're grateful for today? And I give myself those 3 things, my thoughts, my mood, everything shifts immediately. Try that. Try that today. Here's something else. Improve your social connections. And if there's anything that you see you would like, I'm going to give you my email address in the chat box in just a second. You can email me and I'll send this to you. Make sure that you are creative on maintaining those social connections. Remember what I said a second ago, how important social connections are from that Maslow hierarchies of needs? I don't care what anybody say. We are social beings. And so this lockdown has impacted our ability to be social, right? And so we need to find creative ways to be social. I had a lady the other day who was like, Dr. Henderson, you know, I'm an older lady. I live at home. I have nobody else at home with me, and I'm feeling really sad about that. I really want to see my kids. I don't know what to do about that. I told her, how about you tell your daughter to load the kids up, put them in the car, you two go somewhere like a park or something like that, roll your windows down, and you can talk to your grandkids that way. Rather than them getting out, you touching them, you park in the parking lot, roll your windows down, and you guys shout across the way, right? You have to be creative, and there's several ways that you can do that. Planning. Make sure that you're planning your day. That's all this is. Even though many of you may be working from home some of the days throughout since we've been going through this pandemic, you're working remotely, you still should have a schedule. Children, one thing I know about children is that they need to know what's coming next, right? They need to have a schedule. It has to be a set schedule. What's funny is even when we become adults, we still need that too. Because, you know, if your supervisor comes in and is like, hey, changing stuff every day, all day, you would just fall apart. It would really just target that anxiety and stuff that you may have if someone were to do that, or if your days were to look like that. So even though you may be working remotely, still give yourself a schedule. Know what's coming next. Give yourself a schedule about when you're going to answer emails, rather than sitting there all day thinking you have to look for the next email to come and reply immediately, right? We don't do that in the office. And so we shouldn't put that type of stress on ourselves at home. So think about that. Here are some pleasurable activities that I came up with. Again, if you want this, I think this is really neat. I really sat and thought about a lot of these things. But one of the things that's important is, even though we're going through this, it becomes important for you to still engage in things that bring you pleasure. Again, that here's a behavioral thing that can bring you back into balance, right? These are physical things that you can do that will bring you some sense of pleasure. When you bring yourself some sense of pleasure, it brings you back into balance. Family activities, don't neglect your family. Have a dance competition in the house. Throw a party with your family in the backyard or something like that. Children are dealing with this pandemic the same way that you guys are. And so it becomes important that we help them to engage in things that can relieve stress, such as a scavenger hunt, redoing their rooms with assistance, of course. Couples, don't forget about your boo. Many of you have a boo at home. You know, just because you're going through this pandemic doesn't mean that you should be neglecting your boo. Go on a date in the backyard or something like that. Have a dress-up night. Cook together. And, of course, take care of yourself. Me time, declutter your room, have a DIY spa day, so forth and so on. Here are some parenting strategies. We're running out of time, so let me go through this last slide really quickly. I have a link for those of you who are homeschooling, knowing that the virus is starting to pick up again. It may be important for you to have things like this, like museums and stuff like that, that you can click on and go to. And this is the last slide. Maintaining intimate relationships. I put this here because one of the things I know for sure as a mental health professional since the pandemic has started, two things have increased: the rates of CPS issues and the rates of domestic violence. And so I put this in here because if you know someone who may be dealing with a domestic violence issue, if you know someone who has hinted toward it, hey, make sure you reach out to an EAP. Make sure you reach out to HR. Make sure you reach out to a mental health professional, because we can safely provide assistance without making that situation worse. So please be on the watch out for that. Be on the watch out even for yourself if you may be experiencing some things, okay? And here's our EAP team at MD Anderson. That's our phone number. Hey, even though you don't work for MD Anderson, still call over, talk to us. And if you need anything from the presentation today, I will be more than willing to assist you. Hopefully something was said today that was again, concrete, that you can actually use to help you get through the rest of this year and even next year. Okay? Again, thank you so much for inviting me. Take care.
Thank you so much, Justin, for your presentation. That was, I'm sure, much needed for all of us today, so we really appreciate that. And we are going to share these slides and the recording as soon as we can get those up, probably by the end of the week or beginning of next week. So
great.
If anyone didn't grab that phone number or your contact, they can see it then. And then again, if anyone has any questions for Justin or others, just put their attention to in the Q&A box throughout the whole entire day today. And even if we're done with their presentation, we can triage those and get those to the respective presenters later, and we can get that information to you by email if needed. So thank you, Justin, for your time and presentation. And we're going to get Dr. Wilkerson set up now.
Thank you.
All right. So Sylvia, if you will pass him the ball. All right. So Dr. Wilkerson, if you have a presentation, you can go ahead and start sharing that while I introduce you.
Okay.
So Dr. Greg Wilkerson is also from MD Anderson at the Keeling Center for Comparative Medicine and Research. And he has a doctorate of veterinary medicine from Oklahoma State University. I went to SFA, by the way. And he also went to Colorado State University, where he completed his residency in comparative medicine. So Dr. Wilkerson is talking to us today on a review of non-human primate vulnerabilities to infectious agents and COVID-19 mitigation efforts to protect our human and animal population. And I am going to go ahead and turn it over to you. And if you want to put your PowerPoint into presentation mode, we will be able to see that.
Okay. Need to flip that.
You can also use, there we go. Looks good. Go ahead.
Can you see the whole thing now?
Yes.
Okay.
Yep. Very clear. Thank you.
Yeah. I'm gonna.
Right now we see your presentation overview slide.
I'm gonna swap it. There we go.
Okay.
Does that work?
Yep, go ahead.
Awesome. All right. Well, thank you, first of all, for having me to the council and giving us a chance to share our experience with the COVID-19 pandemic here at the Keeling Center. I think we might be able to add something to what Dr. Berkheiser and Linette were speaking to earlier. We have sort of a unique situation out here with our primate populations, and hopefully it'll provide sort of a new perspective of things we had to think about with regard to this pandemic. So we'll start off with an introduction to KCCMR. I'm going to give you the nickel tour. Without seeing the facilities, it's hard to understand, so we'll take a quick tour. I'll discuss the general response of KCCMR to the pandemic, and then there's some animal-specific animal area-specific responses to the pandemic that we had to undertake as well. Give you a summary of the SARS-CoV-2 findings in non-human primates to date. Those have been developing consistently since the start of the pandemic, and then I'll give you a status of the KCCMR throughout the pandemic. So, introduction to the KCCMR. We are the Department of Comparative Medicine for MD Anderson, and we're located at the Keeling Center for Comparative Medicine and Research. From now on, I'm going to refer to that as KCCMR. The primary mission is to support and conduct animal-based research, and we support the preclinical studies for MD Anderson researchers as well as many external investigators. We maintain 8 different types, 13 different species of non-human primates. I'll explain that discrepancy soon. I'm going to use the term NHPs to shorthand for non-human primates. And within our non-human primates, we have 5 breeding colonies of NHPs. In addition to our monkeys, we also keep flocks of chicken and geese that are used in biomedical research. And while we don't maintain colonies of these other animals, we do oversee their use in biomedical studies, rodents and rabbits, pigs, and in the past, sheep and goats, though we don't currently have any. We're located in Bastrop, Texas, and for those of you who don't know, we're actually about 15 miles north of Bastrop and about 30 miles directly east of Austin, about 130 miles northwest of Houston. This is our campus, so we're very rural, and we're on 381 acres. Again, going to give you the quick nickel tour of the campus. So we have our administration building, physical plant, facilities management, and we have our own police force that supports us and protects us, and we're very grateful for them. They're right; those 2 buildings are right next to our entryway into the facilities. We have the National Center for Chimpanzee Care on campus. And things to know about that, we currently have 53 chimpanzees at the center. At our apex, we had about 190 animals in 2010. Most of those animals have gone to sanctuaries, to retirement sanctuaries. And the animals that we currently have are generally with us because they were considered too fragile. They're too aged, or they have ongoing medical issues that make them infirmed and are not good candidates for the retirement centers. So what we have at our center are 53 aged and infirmed chimpanzees, and that's going to come into play later with importance. In addition to our chimpanzees, we have a number of baboon housing areas. I'll describe these more in detail a little bit later. But they're housed in these 3 different locations across campus. And with our baboons, we have about 350 of these animals. This is a specific pathogen-free colony of baboons. For those of you who are not familiar with the term specific pathogen-free, all animals have a microbiome that consists of viruses, bacteria, fungi. And what we've done with these particular baboons is that we have been able to eliminate about 17 different viruses and bacteria that are part of the normal flora. And this is important for this particular colony because the main function of this colony is as a potential transplant research colony. And to undergo transplant studies, they have to go immune suppression. While these viruses and bacteria don't cause any problems in the animals, that have a competent immune system, if they become immune suppressed, as has to occur with transplant studies, they can cause secondary problems. And so this colony, even though we've only had it, you can see that it was established here at the center in 2017. It actually has taken decades to develop. It was developed at another institution, and we became the overseers of this particular colony in 2017. It's a very valuable resource. It's the only one of its kind in the entire world. So there's that. We also on campus have a rhesus monkey breeding research resource, and that consists of about 1,000 different animals. They too are specific pathogen free. They have been specific pathogen free since 1988, and that makes them the oldest research resource of its kind in the U.S., the oldest SPF free rhesus macaque colony. As many of you may or may not know, rhesus macaques are kind of the workhorse of the laboratory non-human primates. They've been utilized more widely than any other type of primate, and again, this is our largest colony on campus. Another building worth mentioning is the Central Services and Clinics and Surgery, and the reason it's important is in this location is where we house animals, specifically macaques and baboons, that are in research studies. And my next image is just to remind me that in addition to our rhesus macaques, we also house pigtailed macaques. Those are the two images to the left, and cynomolgus macaques, which are the two images to the right. We do not have breeding colonies of those two species of macaques, but they are imported into the center on a regular basis to be used in a variety of studies. All told, that building can house about 100 animals. It varies between few to up to 100 at different times. But this, in part, adds to the complexity of dealing with COVID, in that we have more species of unknown susceptibility that we have to deal with. Finally, with regard to the non-human primates, we have the Comparative Medicine and Research Building. This building houses what we call our neotropical animals. These are animals from South America. We have a squirrel monkey breeding colony. This is the only NIH squirrel monkey research resource, meaning that if you're working with NIH and you're working with squirrel monkeys, you are required to get them from us. And it's also the largest U.S. colony of squirrel monkeys. It's a breeding colony, and we'll discuss more about that later. It was established in 1980. It's been at this center since 2008. In addition to squirrel monkeys, we also maintain a breeding colony of owl monkeys, about 350 of these individuals. This is the only source of owl monkeys in the entire United States. If you want to get owl monkeys and it's not from us, you're going to have to fill out CITES permits and get them from outside the United States. It's also the largest colony of owl monkeys outside of one country, Peru, in South America. 350 animals. What I did not mention, failed to mention with the squirrel monkeys, is that we have 3 different species of squirrel monkeys, and we have 4 different species of owl monkeys within our colonies. So it, again, adds to the complexity of dealing with an outbreak such as this pandemic as to what the potential susceptibility of the different animals and the different species may be. And finally, we have a common marmoset breeding group. Looks a little pixelated, I apologize for that. At the end of 2018, we've been trying for many years to acquire marmosets to start this breeding colony, and we were finally able to get 3 breeding pairs, 6 animals total, in 2018. In that basically year and a half since that time, the population has more than doubled from 6 to 13. We have a couple of pregnant females, and we're hoping that that colony continues to expand. Common marmosets are very hard to come by in this day and age due to their popularity as a research resource. And so this is the beginnings of our colony, and so very important to us for those reasons. Finally, the last building is the Large Animal Research Facility. This is where our flocks of chicken and geese are held, and pigs pass through this area as well. whenever they come in for inspection, stay a few days with us, and head down to Houston for the different facilities that might need them there. In the past, this also oversaw the sheep and goat flocks that we kept on campus, the herds that we kept on campus. And this building also contains a few areas for non-human primate housing whenever we're doing work that might require quarantine or bioisolation. A little bit more information about the center. We're a small center. We only have about 150 people here on campus. Our non-human primate census from all those primates I just showed you ranges somewhere from between 2,500 to 3,500 animals any given time. Our personnel is divided basically into three different resources. We have the veterinary medicine section that provides the veterinary care to all animals that are maintained in the center, and they provide study support. We have the laboratory services section. The laboratory is responsible for overseeing those SPF colonies to make sure that they do truly stay specific pathogen free for the pathogens we're looking to keep them out of. It's our clinical pathology laboratory, so all blood work that's done on animals, whether they be sick or whether it's their annual physical exams, is done at the clinical pathology laboratory. All animals that die on campus or undergo a necropsy, whether they be on study or part of the breeding colonies. And so our anatomic pathology units there. And then all these groups participate in the preclinical studies support as well. With regard to research, we have an ongoing discovery research program involved in different types of cancer, HIV, Chagas, hemophilia, a number of different programs engaged in the basic discovery research. Behavioral research is a component of our campus as well. Most importantly is probably the chimp colony. We actually have researchers that come from all over the world. Because of the way our facilities are set up, they're able to watch those chimpanzees and basically and engage with those chimpanzees in a way that allows their research to be done. One thing I didn't mention when we were talking about the chimpanzees is that the chimpanzees are in a breeding and research moratorium since the late 1990s and early 2000s. And so they're not used in any biomedical research at this time. And as I said before, we have an aged population, and in essence, it's a sort of a retirement home, and we're letting them live out their lives. And about the only type of research that those chimpanzees are engaged in is this behavioral research. In addition to those two research programs, we have a preclinical studies, the drug development program. And this utilizes rodents as well as the primates. We do pilot studies for dose range type determination of drugs, PK, TK, biodistribution studies, and also regulated toxicity and safety studies towards the furtherment of drug development. So that's us in a nutshell. It was a quick tour, but at the same time, it gives us just a general feel for who we are and the multitude of species and environments that we're dealing with. So with regard to the COVID-19 pandemic at the KCCMR, I'm going to use the Travis County COVID cases chart as a backdrop to this. While we aren't in Austin, probably 50 to 70% of our employees live within the Austin area. So this actually serves as a nice backdrop as to the type of COVID cases we were dealing with as we worked our way through the COVID pandemic up to this point. So as we watched and the COVID pandemic start to rise, there were murmurings that there were going to be changes coming soon, that there were going to be protocols put in place by MD Anderson proper in Houston, and we started the preparations about March 10th. That was the first time our incident command team met. We basically reviewed and made sure that we were current on our PPE use. And with regard to that, being a non-human primate facility, we basically operate under ABSL level 2 situation at all times, at the very minimum. So we use quite a bit of PPE in our day-to-day usage, made sure that that was all current. We started to implement our first social distancing programs, and we suspended our vet residency program. Up to that point, we basically kept a veterinary resident from the different veterinary schools across the nation. We kept one on campus at essentially all times of the year, and to limit the outside possibility of COVID infections, we suspended that program. The very next day, as we knew might be happening, MD Anderson started to limit travel and meeting size. They suspended tours, visitors, vendors, and a day after that, MD Anderson Houston moved us from level 1 to level 2 warning. So going forward, everything that's in yellow is actions that were taken on our campus specifically, whereas anything in red is coming from external sources. With that in place and knowing our limitations that we had to us, we were able to put together over the weekend our first COVID-19 contingency plan. Now, to come up with this contingency plan, we had to factor in a number of different aspects of our day-to-day life here at KCCMR. First of all, what we had to do was take in what we knew about COVID-19 as of March 16th, and actually prior to March 16th. So we knew human-to-human spread could occur, and we knew that the primary route of infection was going to be respiratory. Direct contact route of infection looked like it was a likely route of infection, and it was something we needed to account for. And then there was a lot of talk early on that indirect or fomite route of infection was a possibility as well. These were all aspects that we had to take into account. There was very little animal data at this time, but with chimpanzees being 98.6% genetically similar to humans, we considered them to be susceptible. We know that they can get many other human diseases, and there was no reason to think that COVID-19 wouldn't be one of those. And so we considered them susceptible right from the start. At this early stage in the COVID-19 pandemic, there were only a few studies done on any non-human primates. As I recall, it was basically 2 macaque studies, each utilizing 3 animals at this time, that suggested macaques could and were susceptible to COVID-19. Other details related to possible NHP infections was based on our previous data from the SARS-CoV-1 outbreaks and MERS, primarily SARS-CoV-1 due to its similarity with the COVID-19 infectious agent. Issues of concern for us, and this isn't necessarily in our expectations, or sorry, our assumptions as to how bad this would be, but we had to consider human-to-human exposure and infections within our employees on campus and within our human exposures that would occur as people returned home and undertook interactions within the community. We had to deal with that, which is very much similar to what everybody else was dealing with at this time. In addition to the human-human exposure infections that we had to take into account with our contingency plan, we also had to worry about human-to-animal exposures and infections. For many places that work with rodents only, one way was to limit the number of interactions that the humans had with these animals. The other way was to limit the number of animals that were around to be exposed. I'll discuss that further as we proceed, but not all those options were open to us. If we got human-to-animal exposure, we then had to worry about animal-to-animal exposure, and this was something that we didn't know as to what extent we were going to have to deal with this. Were the animals, if they became exposed, were they going to produce high levels of virus that were going to and be easily infectious? Was it something that was going to happen to one animal and not be easily spread to other animals? These were all questions that we had to address as we progressed. And finally, was the animal to human exposure. This was actually probably our most, our concern of greatest. This was what we had our greatest concern over, in that we didn't know, again, if these animals became infected, would we have large numbers of animals infected through animal-to-animal exposure? Would there be a single animal? Would we be able to take that single animal and quarantine it and deal with it in a manner that was safe and effective for preventing spread and to humans as well as other animals? Would culling be necessary of infected animals? We were concerned that, you know, if large numbers of animals were to become infected, would the mass of animals and infectious individuals be problematic for us to deal with taking care of these animals with regard to human health? Would we be able to safely address this? Was it going to be dependent on the housing situation of each of the animals, or could we address this safely? If we decided as a center that we would be able to address and take care of these animals that were exposed safely, might there be concerns from the local government, from the state government, from the federal government that would restrict us in our ability to do so? Would there be requirements that they considered the human exposure too likely to occur and would require euthanization of animals that were affected? And then even if the government was okay with the addressing these animals, would we have would MD Anderson be willing to take that risk for us to be dealing with animals that were exposed? So this was something of high concern to us. Other things that we had to take into our contingency plan was just our day-to-day care of these animals. So these are live animals, obviously. They need feed and care daily, 7 days a week, 365 days a year. And so we had to feed and water these animals every day. And in addition to their biscuits, their nutritionally complete biscuits that they receive, and the water, which is actually on automatic waters, but still have to be checked daily, these animals also are given fresh produce daily. And so fresh produce had to be received, had to be washed and processed, and then distributed daily. This is something that, even though their biscuits are nutritionally complete, it adds to their diet and also helps keep these animals enriched with regard to their interactions. In addition to their daily feed and water, our established husbandry practices that we have here at the center include training and novel enrichment items daily. And novel enrichment items could mean something as simple as the changing of toys and manipulata that are within their caging systems. Many times it includes food puzzles in which we take food items and we're able to put them in puzzle devices which they have to manipulate and spend great deals of time working on. While both of these things maybe seem trivial to people working on the outside, things like produce and these novel enrichment items help keep our primates occupied throughout the day. They're very intelligent animals. They require constant stimulation. We basically have 3,500 of these individuals. Think of it like having 3,500 3 to 5 year olds that if you don't keep them busy, they will find a way to get in trouble. And so having the produce, having the novel enrichment is very helpful. By keeping them busy, it keeps them from getting in fights. It keeps them from trying to destroy their caging systems. And so it also helps with the overall veterinary care, just by helping keeping them occupied. Daily cleaning of the housing has to be done. Every single day, the housing, the cagings of these animals are washed down with water to remove all organic debris that might be there, any remnant foodstuffs from the day before. In addition to the daily cleaning of the housing, we have every other week to every third week sanitation of the housing. This is labor intensive. It requires taking those animals out of their caging systems, applying detergents for which the animals cannot be present while we apply those detergents, allowing those to set, and then going in after the detergents have had time to work and scrubbing out the houses and cleaning those as well. Daily veterinary care, any given day, we can have 6 to a dozen animals that require veterinary care for one reason or another. Ongoing medical issues like we see with the older chimpanzees, diarrhea, trauma-induced injuries that the monkeys sometimes occurs with monkeys living with other monkeys. And then in addition to the daily veterinary care, we have annual physical exam requirements. Every year we do blood work. We time these physical examinations such that we know when the animals should be giving birth, and it helps us monitor and take care of the animals. All these factors play back to the daily veterinary care. The more we know about the animals from their physical exams, the better and cleaner we keep their houses, and the more we're able to enrich them, the less the veterinary care is required. Finally, before we were able to put in our initial contingency plans for COVID, we had to start taking other aspects into account. First of all, it would have been ideal if we could have used more personnel to be able to spread out personnel. So we needed more personnel, but that was not available. Hiring freezes went into place. Individuals who were leaving could not be replaced at that time. And so when we needed more personnel, we weren't able to get them. And so we had to make do with what we had. We needed more PPE because to be more biosecure and preventing the spread of COVID, it would have been nice to have that. But like everybody else out there, we had less available to us. The one thing to know and consider about our situation was that unlike some places where you're able to provide a single surgical mask and allow that person to utilize that for a week or several weeks on end when PPE is at its sparsest, we have individuals dealing with outside and manual labor, hauling hoses, scrubbing cages, and both of these things lead to PPE wear and tear. And so it's hard to keep PPE, especially some aspects of the PPE, around for very long under these conditions. While we'd like to increase the amount of PPE and the types of PPE that we'd like to use, we had to take ambient temperature into consideration. It was just starting to warm up at the time. Being Texas, it was quick. We quickly hit 100 degrees out there, and we can only bundle up our animal care staff so much. About 50% of the 50 to 60% of the animal caretakers are working outdoors, so we had to be careful not to overheat them. Because of the amount of cleaning and because of the amount of interactions with the animal we have, it was not uncommon for the PPE to become wet, so we had to factor that into our PPE use as well. You know, N95s were something we would have loved to have had. They weren't readily available, but even if we had them, they weren't real practical due to one, the ambient temperature, but two, the wet nature of the work would have quickly clogged up the ability of those masks to filter air and made it very difficult. Other difficulties that we had to, other considerations that we had to take into account were difficulties associated with animal handling. We had to make sure that while we bundled up our staff and protected the animals from them and them from the animals and the humans from themselves as well, we had to make sure that we weren't taking away tactile function. We had to make sure that we weren't limiting the visual acuity through reducing the amount of peripheral vision that they had, that sort of thing. We had to allow these individuals to maintain their senses and so that they could effectively and safely work with the animals as well. So with all that, this is right back to where we left off of the timeline. We put our first, with all those things into consideration, we put our first contingency plan in place. And essentially what it came down to was the following. We reduced our workforce by approximately 30%. Dr. Berkheiser and Linette discussed that earlier, that was occurring. We were able to do that as well. We limited personnel to one working area on campus. So I just showed you the multiple areas across campus. In the past, there were several people assigned to multiple work areas where they'd work morning in one area and afternoon in the other, but to limit the exposure of human exposure and to preserve the teams as pristine as possible, we limited everybody to one working area on campus. That created some issues and some concerns with regard to being able to perform all our duties across campus because we really relied on that overlap. Even within each animal area, we started to create teams. So in the rhesus area, for example, there may be 12 animal tech personnel working there at any given time. We divided them into 3 teams of 4 people each. So if they were working with anyone in that area, they could only work with people in their team. If at the time, as the quarantine mandate was going, if one person was exposed and one person was identified to be COVID positive, all those that had interactions with that person would have also had to be quarantined as well. So we had to make sure that if one person became exposed, we only lost a third of that group. We increased PPE requirements for individuals. As I mentioned before, we're already at an ABSL 2 at very minimum PPE requirements. So at this point in time, there wasn't a whole lot of additional PPE requirements. The main one being we started including face shields, partially to reduce the amount of airflow that was occurring from the mask and to other people, but additionally, it also helped prevent the touching of face mask, of the hands to the face mask, and it was our hopes that that would reduce any direct or indirect contact and spread of COVID. We increased disinfection and sanitation requirements. We started distributing alcohol to all sections, and basically outside of PPE was sprayed down between buildings, between groups. They were covered over their entire arms, and so we were able to spray down the PPE that was there. We started to reduce a few daily activities within the colony area, so we're reducing our numbers of touches on those animals. And then we also initiated a COVID-19 surveillance program for the non-human primates. We started spelling out what we were looking for and got the technicians, the veterinarians, and everyone on board to be cognizant and to notify the incident command team if there were any non-human primates showing signs of COVID-19. We thought we had it pretty well under wraps, but within a day or two, we started noticing we had some leaks and some areas where there were overlap where we hadn't expected it. Laundry services is centralized laundry here at the campus, and the vehicles that were used were often shared between areas, and so protocol alterations had to be performed to those 2 areas. Housekeeping duty alterations were made to keep the housekeeping personnel out of the animal areas. Before, they would work in front of and behind and within the animal areas. They were limited to generalized areas and areas outside of the animal areas. They were also restricted from going in the offices, worked on outside of the offices. UTPH patrol had been door to door, checking every door, checking every building. They worked with us and started doing outside patrols only of the buildings so that we weren't having any cross-building contamination. Same thing with mail and package delivery to try to limit the cross-building contamination. Packages were delivered to one central area for each building. Individuals would go up there and check it, and if they had packages, would spray it down with alcohol before taking it back to their area. Any maintenance construction projects that were not absolutely essential were suspended. Because there was a drop in communication, we went out and did protocol training at each area. And then as a follow-up, we did monitoring for PPE and protocol following in each area as well. During the same time period, this is when MD Anderson announced upcoming plans to that the labs were going to have to be shut down. All research labs were going to have to be shut down. They had made indications that rodent populations within vivariums and on research projects either be reduced or culled. Any unique genetically engineered mice or any unique genetically engineered rodents could be archived, cryopreserved, and put back. At the KCCMR, we did indeed start the activities to shut down the research labs. As Linette was discussing, we took part in that. We shut down all research labs, and we reduced and essentially got rid of all rodent populations on campus. The NHP resources, this was not a viable option. For the monkeys, this was not a viable option. And in contrast, because we were a breeding colony, instead of reducing, we had numbers going up. Sales of these animals stopped happening, and so while we were making more monkeys, we weren't selling as many monkeys, and so in contrast to what we would have liked, we were having increased numbers during this period of time. You know, with regard to the rodent populations, culling and then bringing them back through reproduction efforts, something you have to consider when you think about non-human primates is that, you know, these primates typically only have one infant per pregnancy. These infants require 3 to 5 years to reach sexual maturity, and then several years to start producing offspring on a regular basis. So if it were to come to the extent that that non-human primates needed to be culled, it would be decades to reestablish a colony of our size. Decades, several, if not 3 or more decades to establish a colony of our size again. So on March 22nd, additional COVID biosecurity measures were undertaken, and the campus was moved into a level 2 to level 3 warning. That's the date that all research was suspended at the KCCMR, and I believe at the main campus as well. And in our activities to get this going, and also continued alterations to the plan kept coming through. And so by April 1st, we were able to provide an updated, formalized contingency plan. We were able to get that in place. This plan, we didn't know it at the time, but this plan basically was a plan we were able to stick with throughout the remainder of the COVID pandemic to date. And so hopefully we're not going to have to go to anything higher than that. Additional changes that were implemented on April 1st included, we began to use modified shift work. Shift work was starting down at MD Anderson in Houston. It looked, I think, a little different, at least for most places in Houston, than what it did at our campus. We still had to provide care and veterinary care and husbandry care 7 days a week, so there was no way we could do 8 hours in the morning, you know, with nobody on campus from 1 to 2 p.m. and then people coming in from 2 to 10. That just wasn't going to work. So we basically broke our crews into 2 shifts. They worked, one shift worked Sunday through Wednesday morning. The other one worked Wednesday afternoon through Saturday, with each shift broken into teams. So going back to that rhesus analogy where we had 12 individuals available for work in the rhesus area, 6 went on one shift, the other one went on the second shift. And even within that shift, if we had 6 on one shift, 3 would be on one team and would be on team A, and 3 would be on team B, so that if we had a COVID outbreak and had to quarantine individuals, we at least had some individuals left behind to deal with the husbandry needs of the animals. Smithville, our sister station out here, there's another campus over in Smithville, Texas. They were largely closed, and as during this time period. And I have to say this worked to our benefit. Dr. Dent and her crew were able to provide us with additional PPE that they weren't needing to utilize at that time. It turned out to be hugely helpful to us. They had disinfectant, they had alcohol available that we were able to utilize from them. And one thing that I wouldn't have foreseen being so helpful, but the housekeeping staff from Smithville, since it's only 30 miles away, was able to transfer over to our campus. And that really helped us out. We were able to actually assign a single housekeeper to each animal area. So now we not only had people staying in their own area, but housekeepers that used to have to work across multiple animal areas were able to stay in one animal area alone. The housekeeping staff, and again, kudos to Smithville and to our RAF crew. They worked with us so well, and they were able to disinfect the animal areas between shifts. So on Wednesday afternoon, when nobody was around between the shifts, they would completely disinfect the area so that shift 1 wasn't intermingling with shift 2, and then they would do the same on between Saturday and Sunday. They took over bleach and alcohol production and delivery for us. This was something that we did in each area, but because of the reduced staff, the housekeeping staff was able to actually aliquot bleach and produce fresh bottles of bleach for us each day and distribute it to each section. Clinical pathology, daily received blood samples, and so we were getting numerous people down here in the building where I actually reside a day from all different sections. We were able to move the receiving area for all the clinical pathology samples, all the blood samples and swabs and everything else that we analyze on a daily basis. We moved the receiving area to outside, and we had a doorbell in place that we're able to utilize. And so now we're receiving everything outdoors, keep people out of this building. Something that we thought about long and hard was that we started using hardy produce only, and that hardy produce is just a term we came up with. Up to this point, as I mentioned before, all the animals get produce enrichment on a daily basis. Up to this point, we had 40 to 50 different items that we were purchasing on a regular basis that we would receive, and it wasn't a problem. Receive it at the receiving dock, and they would get those produce items and take them directly over to the different areas. Because of the possibility that of fomite route of infection, the possibility that perhaps that produce might contain COVID-19 droplets or whatever, we wanted to be able to allow it to set out on the dock. It was coming out of a refrigerated truck that was delivering it. We wanted it to be able to sort of set out on that dock for 24 hours. So we ended up limiting our produce down from 40 or 50 items to 12 different items that could withstand setting on the dock for 24 hours. Things like apples and oranges and celery, stuff that wouldn't go bad. A lot of our leafy, red leaf lettuce and that sort of thing that wouldn't have fared well in that time frame were minimized. And then we also suspended all animal training and daily enrichment items. And we knew, and we still know that, taking away some of this enrichment device, taking away the training, which the animals engage free will on their own free will, helps keep them occupied and helps keep them out of trouble. But knowing that this was going to reduce the number of interactions that we had between the animals, which is something we had to do. What it also did is that there are 6 individuals that are part of the behavioral and enrichment crew, and they were able actually to be used in the different animal areas. So when we suspended animal training and enrichment, we were able to take those 6 individuals and disperse them throughout the other areas. Finally, during this time, we were able to finalize our first quarantine contact tracing protocols. We made these were formulated through a correspondence with our MD Anderson employee health and well-being officials. They interacted with us a ton, and thank you, Garland, for helping initiate that, and thank you for all those individuals down at MD Anderson. A lot of that was the human-to-human quarantine and contact tracing protocols that we had to get in place. We also had a huge amount of correspondence with our colleagues at 8 different national non-human primate centers across the nation. They were calling us, we were calling them. We were all trying to get a handle on this as to what this was going to entail, how we were going to be able to deal with the animals and people that were in interactions with non-human primates. At least the quarantine protocols for the animals and for humans included the potential use of N95s or PAPR. PAPRs were really are sort of our last resort for the quarantine usage, mainly because we only had 8 of those devices, only 8 PAPR devices, and PAPR hoods were very difficult to come by. And we had a use for those PAPRs that I'll discuss more in just a second. But N95s were something that we needed to know we could go to if we had individuals that were positive or if we had animals that were positive and we needed humans to interact with those animals. We needed to know that we had a reliable resource. And so to that, essentially every single one of our animal handling personnel had to be fit tested for N95s. And that was a chore. And, we received a little feedback that we might be a little excessive with our fit testing requirements and needs. But after we were able to explain why we were doing what we were doing, we didn't know who of the animal handling personnel or when they might need it. So we had to get everyone N95 fit tested. Garland worked with us to get everybody tested on campus because N95s were so precious. We actually did the fit testing with these N95s, and then we were able to gas sterilize them, and we've had them repackaged, and they've basically been awaiting use since that time. So we were able to not have to lose that many N95s. We had a very limited number that we had here on campus to begin with. And then the one thing I'll say is that while we first finalized these quarantine and contact tracing protocols in April, there hasn't been a week gone by when these haven't changed, and we haven't had to update. Just they've had to be very dynamic over time as the situation changes and as the guidance from the CDC and environmental health and well-being have changed. We've had to change those too. We organized 3 veterinary COVID-19 response teams, so now we have 3 specific veterinarians. So if there's an animal that is suspicious for COVID-19, one of these 3 vets and designated technicians will go and address this. And we have worked through the process as to how to be safe about addressing these animals that might be COVID-19 positive. And then finally, we've had to implement area-specific PPE protocols, and this is where we're going to get back into pictures for a minute. So area-specific requirements, we have very different species throughout campus. They're in very different settings, so what did we have to deal with in the different areas? So I told you before that what we have left of the chimpanzee population, again, at one time almost 190, we're down to 53. The 53 we have left behind are very aged animals and or infirmed. These animals have arthritis or ongoing heart disease or a number of different generally age-related issues. And because of that too, most of these animals are medicated daily. So we're basically having to make contact, some sort of contact with these animals on a daily basis. Once, twice a day, some of these animals are having to receive medications. They're very good at it. They've been very well trained. They know right where to go to get their cup of Gatorade along with their pill that they're having to eat, or their cup of strawberry milk, or whatever they prefer to take their medications in. But we had to make alterations. This is a close-up of the chimpanzee housing areas that I showed you before. It became a little pixelated. I apologize for that, as I had to zoom in on Google. But I wanted to point out a couple different things. So there's 2 different types of housing styles here. One is an open air corral, and the others are primadomes. Both of these structures, so the outdoor part of these structures are the circles. The animals can go basically in and out 24 hours a day. There's a tunneling system that leads to an indoor area. All these animals have been so well trained to go in and receive their medications, to, if observations needed to be made, all these animals have been very well trained to station, to come to a certain place in these areas and inside. And that is a problem. We did not want to actually congregate with these animals inside as much as possible. The chimpanzees, because they are older and infirm or infirmed, they're housed, males and females together. All the females are on birth control, oral birth control, because they are on a breeding moratorium. So we needed to make sure that they got their prophylactic pills on time every day. And so this was going to be a problem to us. The one thing about this setup, though, that really worked for us is that these animals, these groups, are separated indoors by thick walls and outdoors by 20, 25 feet each. And so there is little potential for one group to spread to another. About the only way these animals were going to become infected was from human to animal contact. About the only way that they were going to have spread was from a human taking the infection from one group to the other. So the groups were very well isolated. That was going to work in our favor when we came to defining how we were going to handle these animals. In addition, the baboon area. This is a breeding colony. We have 150 offspring approximately born a year. The thing about baboons is they're non-seasonal breeders. That means they have infants, they have births all year round. Our main concern with this group was then the SPF nursery concerns. I pointed out earlier that we have baboons in 3 locations, and the reason we do is because to the far right is our SPF baboon colony. These groups of animals are known to be free of all those microbiota, the viruses and the bacteria that we want to have them free of. That group in and of itself reproduces yearly and produces more SPF baboons, and those animals coming from SPF dams and sires are known to be SPF as well. But to help us grow our colony and to increase the genetic variability, we also rely on baboons coming from this conventional baboon housing. So animals are born to dams and sires out here, and shortly after their birth, they're taken to the baboon nursery where they're hand-reared. They're tested for about 6 months to make sure that they are free of any of the microbiota we want to exclude. If they are, they're put in juvenile groups, and for about 2 to 3 years, they grow up in these juvenile groups with other baboons, at which time, if they are still free of all diseases, they can be transferred into the baboon resource. The baboon nursery is fairly safe with regard to its biosecurity protocols it already had in place. Since they're having to deal with animals that they're trying to keep out all external sources, there were extensive biosecurity procedures. Not much had to be changed there, but we were dealing with this exchange, and so monkeys are moving across campus, and it was something we had to be careful of. Again, this sort of recycled sign is just to show you that the SPF baboons that were already living in the SPF colony were reproducing and creating babies on their own. This is a shot of the baboon area from above. This used to be the chimpanzee colony too, but with the numbers of chimpanzees declining, the baboons have been moved up to this area. The circular spaces represent the outdoor areas for the baboons, and the square spaces represent the indoor areas. And so the chimpanzees and the baboons were very similar in their requirements that we needed. All activities that we could needed to be performed outside of the caging structures. So this included feed, animal treatments, medications, anything we could do outside, we did outside. Something that we used to do before, when we used to wash down the inside areas of these, the animals were allowed to come in. Some of them like to play in the water when you're cleaning down the area, but to try to limit the exposure of humans to animals in these enclosed spaces, we actually started isolating the animals outdoors when we were cleaning their indoor pens. Because the animals were separated from one another, the baboon groups, like the chimpanzee groups, were so far separated from one another that the only way they were going to get infected was from one human carrying it to the next. There was complete alcohol disinfection of the outer PPE performed between those groups. Teams were assigned to specific groups of animals in the chip and baboon area so that if we had an individual who was COVID positive, they wouldn't work with groups 1, 2, and 3 today and 4, 5, and 6 tomorrow. We were trying to limit the spread of COVID. If it was going to happen from human to animal, at least limiting it to a number of groups was helpful. I talked about the N95s and the PAPPers before. N95s would have been nice to have to help reassure us that we weren't spreading a disease to those animals. Not realistic due to heat, due to the humid nature of the work. PAPRs we had very low numbers of PAPRs and low numbers of PAPR hoods available to us, and we thought that the use of these PAPRs were better utilized elsewhere. With regard to the macaques, these animals have about 250 animals a year. They are seasonal breeders, and so they have babies only between about a 4 or 5 month period each year. Unlucky for us, it just so happened that it starts about April and it ends about end of July, August is sometime. So as we're enduring the changes that are having to occur and having to make changes with regard to our personnel, this is a big time of year for us, and about we can expect about 250 animals to be born between April and the 1st of August. And so it's going to be a very busy time. So that was one concern, that we knew we were going to have to deal with more animals, more veterinary care. You know, occasionally the animal needs assistance in birthing. C-sections are done occasionally, and this was going to require more input. One thing I'd point out real quick is there are 2 different types of housing structures. On the left are what we call corn cribs. These structures house a single group of animals. Most of our animals are housed more like what's happening on the right, though. These are called buildings or houses, and within each house are multiple cages. And the animals actually make frequent contact with the animals in the group next to them. So this is the housing structures from above. I'm going to focus on one housing structure. One housing structure has a central hallway, and on each hallway, down each side of the building, are 5 to 6 individual rooms. Because the animals can have constant contact with each other, it would not be unheard of that if one animal in one room were to become infected, that it wouldn't just spread down the side. Now, there's about an 8 to 10 foot hallway between the two, so spreading across the building may not have been as important. The corn crib structures, I've highlighted 4 of the 8 down there below. They're about 10 to 12 feet away from each other, and so we didn't think that the chance of that spreading between animal groups was likely. But with these buildings, it was very likely that if there was an animal in one side and the virus produced a viremia at all, that we would end up with entire sides of buildings infected. So with the rhesus section, we also wanted to perform all activities outside that we could. Alcohol disinfection between individual corn cribs, so there's individual round buildings, or between individual sides of buildings. Again, we assigned teams so that specific people were working with specific animals. We are at capacity almost all the time with these animals, and so unfortunately there was no ability to spread the animals out. N95 and PAPR use would have been nice, but again, and reassuring, but it was not realistic. Finally, we come to our comparative medicine research building. This is the building where our neotropical or South American animals are housed. This is the building from the top, and just real quickly, that building contains a research labs. This is our discovery research labs on one side of the front of the building, on the other side of the pathology labs. In the back of the building is rodent facilities. We're not going to discuss those any further in this talk, but the squirrel monkeys occupy one big room in one half of that building, and the owl monkeys occupy 2 big rooms in the back half of that building. The purple M represents the marmosets. They're one room. They were basically 4 cages of marmosets. Alcohol isolation, alcohol sanitation between individual cages, but not a lot else to be discussed there. So we're going to focus on the squirrel monkeys and owl monkeys. Squirrel monkeys produce about 200 babies a year, 200 offspring a year. Now, I discussed before that sales, we have about 200 babies born a year. We stay largely near capacity during this time too, and having 200 babies a year but not being able to sell any animals, it was a possibility that crowding could become an issue. And so this was a worry of ours. Real quickly, on the left is a run for the animals. This is an empty run. There's no monkeys in there, but the monkeys would occupy 2 of these runs. And the 2 runs, if you look to the right, you can see the runs were abutted right next to each other, and interactions between animals, between the different groups, is not uncommon. So that they're hand fighting, they're playing with each other between the groups. They reach around the corner. They can't actually have face-to-face contact, but any direct transmission of this virus was a theoretical possibility. And so looking at the squirrel monkey area again in the blue, if we get a little closer to it, this is the room. There's one large room with 15 groups of animals on one side, 15 groups of animals on the other side. The three smaller rooms are rooms that were typically used for research on these animals. And what we were concerned about was that one animal got infected, as represented by the star, and it would just travel down the side. So it would not take much for 50% of our population to be affected by COVID. And so what we did is, what we decided to do is we took out groups of animals and put them in those research rooms to create fire breaks, so that if we had a spread, it would be limited. That is very similar to the same situation that we had in the owl monkeys. They produce about 70 offspring a year. Crowding may become an issue. They are situated very much the same. If you side to side, abutted one next to each other, would not be hard for these to spread. If you look at the owl monkey area closer, they are in two rooms, but there's 30 cages on one side separated by a waterfall, and 30 cages on the other side. So any infection could easily run down and infect a fourth of our colony. We did the same thing with those animals. We created preservation groups, put fire breaks in between the animal cages, and put these preservation colonies into the research rooms. So for neotropical section, we created preservation groups, as I just discussed. One thing I would point out is that these were all indoor facilities. They're kept warm, about 80 degrees. They're constant humidity of 80 degrees or so, 80% or so. There's no direct sun, wind, or heat to help break down the virus in those rooms. So this is where we ended up using the PAPRs. All neotropical personnel were required to utilize PAPRs, as we thought that if there was contamination of a source, it would likely persist in this environment for very long. We used complete alcohol disinfection between the groups, between the fire breaks, between the rooms, and then there were teams of individuals assigned to specific groups. So that's entails the second contingency plan. We stayed like that for about solid for about 2 weeks, and at the end of 2 weeks, we started allowing some maintenance projects, some laboratory work to resume. On May 1st, the governor started plans to reopen Texas, and some of those plans went into effect. Only in mid-May were we able to finally get an assay for COVID-19 for detection in non-human primates. We developed that in-house. Up till that point, we did not have one available to us. Luckily, we didn't have to use one up to that point, but we didn't have anything available to us had we needed it. There were additional plans put in place to reopen Texas on 5/19. By 5/21, by May 21st, the campus was downgraded from level 3 to level 2 warning. 5/21, May 21st, about a month and a half after we went to the shift work, we were able to come off shift work and we're able to spread that out. Everybody came off shift work at that time except for our neotropical personnel who were in PAPRs. Because we had limited number of PAPRs, we were actually awaiting the delivery of 2 more PAPRs because I didn't have enough PAPRs to accommodate everybody on the same shift. They had to wait an extra 10 days, and then they came off shift work as well. Finally, on 6/17, we resumed some non-human primate work. Right about the time we started that, there was a report, sort of the first report of mass euthanasia is required of an animal species. There were about 100,000 mink identified in Spain that were COVID-19 positive, and the government had deemed it necessary for human health to euthanize those mink. That was kind of our worst case scenario that we worried about for that animal to human spread. But at the same time, we were getting a lot of data related to COVID-19 infections in primates. I'll discuss that more in a second. By August, our overarching association that oversees primate work started releasing releasing guidelines for work and had amassed a large amount of information with regard to non-human primate COVID and COVID infections. Commercial diagnostic assays, which had been developing this entire time, were now readily available. We had assays for antibody or PCR available to us. And so finally, on the latest change that has occurred was that on September 7th, we actually downgraded the neotropical PPE from PAPRs. They've gone back into surgical masks, which was very helpful to us because they were using one-time PAPR hoods from 4/20 from the start of April until about mid-June, at which time we were able to get new PAPR hoods. And from mid-June till September, they were in their second PAPR hood. And so these single-use PAPR hoods had been used for about 2 to 3 months apiece. So real quickly, I think I have 3 more slides. What was found about non-human primates to date throughout this entire thing was that we now know that macaques, baboons, a type of monkey called African green monkeys, squirrel monkeys, and marmosets are susceptible to infection. The clinical disease and the level of viremia varied, but the general finding is that disease was relatively low, and that the levels of viremia were low. Some studies found that older monkeys, there were a total of 3 of these studies done, have increased disease manifestations or decreased immune response. Our big caveat to all this research is that we're dealing with neonatal animals, we're dealing with pregnant females, we're dealing with extremely aged animals which weren't included on the study. We don't know as to what level of infection these animals could get. Throughout this entire time frame, there are hundreds of thousands of interactions probably between COVID positive individuals and non-human primates going on at this time. And to date, there has still only been 1 human-to-animal transmission of 1 animal, and that 1 animal did not seem to spread it to other animals, so no animal-animal transmission has been identified. All good news for us. So in general, the conclusions of the SARS-CoV in non-human primates to date is they don't appear overtly sensitive to natural infection, disease manifestation, or animal-to-animal transmission. ABSL2 has been deemed adequate to reduce the risk of natural SARS-CoV transmission, and screening programs for antibody or PCR testing are being recommended. However, we aren't currently doing that for reasons I'll talk about in 2 seconds. Our response involved collaborative efforts between us, the MD Anderson Cancer Center in general, and our NHP faculty facility colleagues. There have been very few cases of COVID-19 individuals within the KCCMR Center itself. There have been several employees who have been known to be exposed to or have cohabitated with other known COVID-19 positive individuals. But to date, at least to my knowledge, we do not have any suspicions that there have been COVID-19 infections that originated from the KCCMR due to probably the standards that we're keeping. However, having said that, the majority of the KCCMR personnel remain untested. To date, none of the primates that we've tested have been identified to be positive for SARS. That SARS screening has been limited to animals that have maybe clinical signs suspicious of COVID-19 and those imported to the center for use. We may incorporate antibody testing into yearly testing on the future. Last slide. We believe the pandemic mindset that we were able to adopt at the center has been critical to our success. We're desperately working to prevent and or reduce any pandemic fatigue. We keep trying to remind everybody of the importance of maintaining the PPE and the protocols that they've done to this point. The data suggests that the worst case scenario that we envision as a possibility for non-human primates and COVID-19 can be avoided with proper care. However, in that we still haven't seen data from pregnant animals or animals, older animals. We are going to remain vigilant on that front. We have increased biosecurity protocols that remain in place. They've backed off some, but we still have them. Quarantine and contact tracing protocols keep getting updated, and enhanced PPE and protocol measures can be reinstated quickly as needed if we sense that there is a need for that. With that, I'd say thank you. Please come see us once this pandemic ends. We love to show off our campus. That was a lot of information fast, and I apologize that I may have put too much in there. Let me know if you have any questions, and here's some contact information. I think I went over my time a little bit, so please feel free to reach out to me as needed.
Thank you so much, Dr. Wilkerson. That was a great presentation, and I think, you know, it's very interesting to see what y'all are doing out there, and it's a nice break for us that, you know, those of us that work in the medical center and, you know, work with human primates. So I was very impressed, and you know, it's important to know, you know, kind of what's going on with all the possibilities and transmission. So that was very interesting. And yes, we will definitely plan on coming out and taking a tour and seeing you all once we can and once it's safe. I think that would be great. So with that, thank you again. And if anyone has any questions, you can go ahead and enter those into the Q&A box, and we will triage those to the presenters after we wrap up here. So I'm going to go ahead and just do a quick wrap-up session since we're a little over our time. We have some upcoming events today, tomorrow, and then there's the last collaborative 2020 NIOSH ERC webinar series. So if you go to our website and swcoeh.org, scroll down, you'll see upcoming events. The one that you'll probably be most interested in, because it offers CE, you guys stay tuned because we're doing another series in 2021, and these are free. And this is a collaboration between all NIOSH ERC continuing education programs, is this right here. So click on that, attend the last one in December, and then come back to our website towards the end of December, beginning of January. We'll have this 2021 series up and running, probably not completely, but at least the first few. So I just wanted to point you to that. And then, of course, you can get more information about the Southwest Center and all the programs and resources here. We do have a COVID-19 resource site. You can go to that link. It's in English and Spanish. You can see all of our response efforts here. The last thing we did, was that yesterday, 2 days ago, was a talk with the Health and Safety Council, and that'll be posted here. And I think that's really good to review. We talk about our normal health and safety best practices, but we also talked about pandemic fatigue in the last slide there. So I'm going to stop sharing. I just want to thank you all for attending. Thank you again to all of our presenters. And thank you, Sylvia, for hosting and coordinating everything. So if you have any questions, feel free to email me. I do see one thing in the Q&A box. Oh, so just thanks again. And we'll get this sent out to you. We're still working on our YouTube, but we have that up and running. So if you attended the last GHIHC in October, we'll also have all the videos up there for those that attended. We'll give you access to that, access to these, and access to the slides. So be safe, have a great Thanksgiving, have a safe Thanksgiving, and we will see you next time. Thank you.